Yes, we are, absolutely.
Okay, great. So welcome everybody. We're really happy. We're excited about the day and happy to have you all here with us. Okay. Next slide. So we are pleased to kick off this virtual research day in collaboration with Guidelines International Network North America, Cochrane Canada, and Cochrane US. And this has been truly a collaborative effort between our three organizations to provide a venue for sharing of scientific knowledge. And we really appreciate the collective efforts to bring this research day together under a short time frame. And we look forward to future opportunities for collaboration. And I'm going to give a quick overview of AHRQ and the EPC program. So in the back of your mind, you can think about different ways you might want to work or collaborate with us, or even just give us input into our work in the future. Next slide. Oh, the slide before that. Yeah, that one, sorry. So AHRQ's mission is to produce evidence to make healthcare safer, higher quality, more accessible, equitable, and affordable, and to work with the Department of Health and Human Services and all our other partners to make sure that the evidence is understood and used. So we have a big role in both evidence synthesis, evidence generation, and evidence implementation. Next slide. People sometimes wonder where AHRQ sits in the kind of federal research landscape. And just briefly, you know, NIH does biomedical research, FDA does drug safety, CDC does research on public health, and AHRQ does really research on care delivery, on how to improve care. But, you know, our EPC reports really cover all of the waterfront because in order to improve care, we need to get the best evidence into practice. Next slide. So, and this is just a visual which shows, you know, how important the critically appraised external evidence is, which we actually integrate into our dissemination and implementation portfolio and getting this knowledge into practice. And, you know, aligned with a learning health system, then this, you know, effort generates new data, which generates new evidence, and the cycle begins again. And more we're focusing on living reviews to be able to stay updated with the latest evidence. Next slide. So many of you are familiar with the EPC program. It's 20 years old now, over 20 years old. It was established in 1997, and it supports the EPC programs, which, you know, really have the expertise to do high quality systematic reviews. And we really, then we take these reviews and we partner with external organizations to promote evidence-based decisions on a whole range of topics, both clinical and healthcare delivery. Next slide. So our topics are nominated from the public, professional societies, other federal agencies, and Congress. And you can see on this slide a range of some of our partners. And next slide. And so the role of the EPC program is really to provide the best evidence to inform decision-making, whether it's research funders identifying research gaps for research funding initiatives, guideline developers to develop guidelines, and healthcare policymakers to provide the needed evidence. Next slide. And so, you know, I'm sure all of you know, there's a lot of innovation going on in systematic reviews now and evidence syntheses, and AHRQ has a big focus not only on doing the reviews, but on, you know, methods development. And more recently, we're partnering with learning health systems to help them use the evidence and developing materials to make it easier for them to do that, including data visualization and, you know, incorporating this work into their clinical pathways. Next slide. So we're excited about two new tools that we're working on. Some of you may have worked with these, but SDR Plus is a systematic review data repository. We're hoping that you're all going to use this. It's going to be easier and easier to upload your data from systematic reviews so everybody can share them, and it will actually expedite do updating and doing living reviews. And the other thing we're really excited about is NextGen, which is going to be an online data visualization tool to really be able to look at our EPC reports and get the data you need in the way you need it very quickly. And it will make it easier for decision makers to understand what's in the reports and what the evidence is. Next slide. So for more information, here's some links we have a listserv if you want to be updated on new reviews or drafts posted for public comments. We always welcome nominations for topics. And last slide. So just again, want to thank, all the organizations that have, contributed to this. And I'm really looking forward to a great day with a lot of great presentations. And once again, please feel free to reach out to us to collaborate, partner, or also just share your ideas for how we can make the EPC program even better. So thank you very much.
Thank you so much, Arlene. Up next, we will be hearing from Mary. Mary, did you unmute your line on your own just now? I think you did.
Yes. Good morning, everyone. I echo Dr. Bierman's welcome to the North American Systematic Review Methods Virtual Research Day on behalf of the Guideline International Network North American community. In my final months as chair of GIN North America Steering Group, a member of our steering group, Karen Robinson, who is also with the AHRQ EPC program, shared the idea of this event. I had the privilege to shepherd the idea to the full steering group, and the response was resounding support. Not only are systematic reviews fundamental in clinical practice guideline development, our community values opportunities like this to learn and exchange. We were able to work with GIN headquarters to unearth abstracts that had been submitted to the 2020 canceled GIN 2020 annual scientific conference and get connected to Cochrane Canada. With pride, GIN North America is pleased to be a collaborator on today's event, and I'm proud to have used my ending chairwomanship time in this way. Enjoy the event.
Thank you so much, Mary. All right, Adrian.
Thank you, Celia, and good day, everyone. I'm Adrienne Stevens, Managing Director of Cochrane Canada. And as it relates to one of the sessions later today, I also serve as a co-convener of the Cochrane Rapid Reviews Methods Group. Thank you for your interest and participation in today's event. On behalf of Tiffany Duke from the Cochrane US Network and Holger Schoenemann and myself from Cochrane Canada, we are grateful to our colleagues from the AHRQ EPC program and GIN North America for inviting us to partner in this event. It has been a delight to work with this group, and we too look forward to opportunities to be able to partner together again in the future. We also thank Cochrane centrally for facilitating the connection to authors of abstracts from this year's colloquium that, as you know, are published as a supplement to the Cochrane Library. Please take the time to browse through. As it relates to Cochrane Canada and the Cochrane US Network, we encourage you to check out our work and our involvement in the response to COVID-19. The website URLs are provided on the screen here with you. We would love to engage with you. We hope you enjoy today's event. And with that, I hand it back over to you, Celia.
All right, well, thank you everyone for that warm welcome. And I echo, it has been such a pleasure to work together, and I'm very happy to be bringing this event to everyone today. A few gentle reminders to keep our meeting productive. Please mute your line when not speaking. We will mute it. If you are having trouble, we will mute it for you. Please, listen and introduce yourself. If you'd like to speak up, please say your name. And if you have questions during the presentations, feel free to send them in the chat, or you can wait at the end of each speaker. We will have a minute or two for questions. And if you have any issues, feel free to send an email to that address at the bottom of the screen. As a reminder, this meeting is being recorded, and we are hoping to distribute it to folks who perhaps weren't able to attend today. Next slide, please. And so without further ado, we will be starting our content now. So our first session is going to be on non-randomized studies. We will be, the session will be moderated by Karen Robinson from the Johns Hopkins University EPC and also the GIN North America Steering Group. And up first, we will be hearing from Julian Higgins, who is presenting on behalf of Rebecca Morgan, who was unfortunately not able to make it today. But Julian, I see that your line is unmuted. You are welcome to start sharing your screen now.
Thank you. Time for me to go? Great. Well, I am very honored to be able to present to you here today. I feel like an interloper from over in Europe. I know it's a North American event, but sadly, as Celia says, Rebecca couldn't be here today. So I'm talking about a tool to assess risk of bias in non-randomized or observational studies of exposure, not on interventions, which I think is probably of interest of a lot of people here. But this is a piece of work that I've been doing with a number of people you can see here. So, well, here in Bristol, as I'm sure many of you know, we've got a strong interest in developing tools to assess risk of bias. And one of our most prominent was the tool for randomized trials that we published in the Cochrane Handbook in 2008. And that's now I think the most widely used tool for assessing risk of bias in trials. We then moved on to looking at non-randomized studies of interventions that would also go into things like Cochrane reviews and so on. We published in 2016. And last year we updated the risk of bias tool, drawing on some of the insights we gained developing Robin's I. And in turn, some of the further insights we gained in Rob2 for randomized trials, we're putting into a new version of Robin's I that will be coming soon. But an area that we have not produced a tool as yet is looking at, again, at non-randomized or observation studies, but of exposures rather than interventions. There are a lot of tools out there. Some years ago, back in 2007, we published a review of tools. So we found 86 even back then, although we didn't think any of them were really quite suitable for use in a systematic review. And a lot have been developed since then. So having developed Robin's I, and perhaps we had a premonition about this when we named it with the I on the end, the idea it was quite obvious that perhaps we could translate this thinking into looking at non-intervention exposures. And indeed, the work is leading to a tool that we're going to call Robin's E. It's not yet available. And it really started with Rebecca working with Holger Schunemann and Chris Thayer, taking Robin's I and thinking through the extent to which it could work for exposures. And the team grew to bring in Andy Rooney and Kyla Taylor from the NTP, and then Jonathan Stern and me from Bristol, we came on board. And the team, as you can see with this list here, is grown. We've got a lot of people who have been involved in this. We do have a core group that are trying to push it forward. What is it that we're really talking about when I say exposure? In a sense, interventions are exposures, but the notion of exposure really could straddle a huge range of things on a big continuum, from things that are very much intended, like interventions, to things that are very much unintended and can't be controlled. And they go through things like personal choices. Obviously, there are Cochrane reviews on manual versus electronic toothbrushes. Is that an intervention, or is it just a choice? And then you can see how the continuum moves down. We're really focusing on, in the first instance, are exposures such as occupational and environmental exposures, particularly because they're potentially modifiable, but also they raise a lot of interesting issues. And then some of the key challenges we're facing is defining the exposures, because unlike interventions, it can be very difficult to define when they start. They frequently change over time, and they come in a very huge range of doses and periods of exposure. One of the core aspects of any risk of bias assessment, in our view, is being able to establish what it would look like if there was no bias. How can you assess risk of bias if you can't define no bias? Which means that at the heart of any tool, we need to define what no bias looks like. And as some of you will know, the way we defined it for Robin's I for interventions was by imagining a hypothetical randomized trial addressing the same question. Of course, we can't imagine a randomized trial as such for an exposure, but we still need to define the causal effect of interest. It's fundamental to define what it is that we would want to know if we knew it without bias in order to think about risk of bias. And so one of the big challenges we're facing, and why one of the reasons that it's taking us a long time in negotiating with people working in the field, is how we can do this. And personally, I find it probably easiest to think about this idea of a counterfactual. If what would have happened if people hadn't been exposed, or had been exposed to a different dose or in a different pattern. Some people would prefer the idea of a target experiment, which builds directly on the idea of a target trial, as we used in Robin's eye. And this is it's a hypothetical experiment, imagining we could actually assign exposures rather than just having them observed. And of course, we could assign an unlimited number of different plans to encompass the range of times of onset and doses and patterns of exposure that people might receive. One of the beauties of a target experiment approach is that it very explicitly draws a distinction between what is risk of bias and what is applicability or indirectness. Because risk of bias is the difference between what we see in an actual study, an observational study, and the target experiment underlying that study. That be, what would we do if we could actually control the exposure and keep everything else constant? And that applicability is the difference between the target experiment specific to a study and the research question that we primarily want to answer. And a very, very important aspect of the notion of a target experiment is that it probably will not be feasible and it probably will not be ethical, but it's still a useful device for defining the causal effect that we're interested in. So we have...
Julian, quickly, would you mind speaking up just a little bit? It sounds like some folks might be having a little trouble with audio. I can hear you okay, but it sounds like others might be.
Sorry, I'll get close to my microphone. I hope that's better.
Yeah, that is better. Thank you.
Great. So we have developed a tool, and we had a fully worked up tool that we piloted last October. We had a 2-day event in Bristol, brought a lot of people over from North America and elsewhere to have a play with it. We had a lot of feedback, some important limitations in how people were finding it was working for their field. So although we would have hoped to have had the tool to present to you today, we haven't quite been able to iron out all the controversies that we've created. But what we are currently working with is a tool that has 7 domains listed here. Risk of confounding, as we'd expect to encounter in an observational study. Risk of bias in measurement of the exposure, and this is really the most challenging. This is where things are really very different from interventions. Interventions are usually quite discrete things, at least to start very discreetly, even though they become more complicated. Exposures clearly do not, and I mentioned some of those problems already. Third domain is bias in selection of participants into the study, dealing with a number of selection biases that are important in non-randomized research. The fourth is risk of bias due to post-exposure interventions, because if exposure leads people to receive an intervention that attempts to mitigate the effects of the exposure, then that would distort the effect we'd see compared with if they only had the exposure. So we want to look into that within the tool. And then the last 3 domains around missing data, measurement of outcomes, and analysis and selection of the reported result, very much in line with what I suspect a lot of people are used to thinking about when thinking about trials and other intervention studies. For the tool is structured much like our existing tools, that within each of those domains we have a number of questions to answer, and the answers to those questions lead to a risk of bias judgment for each of the 7 domains. And these are the categories of judgment that we're currently working with. We think it's important to root it all in the idea of low risk of bias, even if we don't expect observational studies to get there, because that's aligned with our definition of what freedom from bias would look like. And then we have some risk of bias. We have clear risk of bias where there are clearly some important problems. And then we have a very high risk of bias where the study is very problematic in that domain. And just to say a bit about the wider context, I think even more so than looking at interventions research, when we're looking at exposures, we need to look at risk of bias assessment as part of a much bigger picture. And certainly when we go into it, we need to have do some planning to inform the entire set of risk of bias assessments within a systematic review. So make sure we've got the research question very clear and think very carefully about what exposure we're interested in looking at, and about potential confounders. Very important to identify those in advance so that we can check in each study the extent to which they've been addressed. And then when we get to each study, for each of the key results we're pulling out, we do a risk of bias assessment according to the core of the Robbins-E tool. But a really important step for many of the people we're working with, particularly when they're looking at hazards of environmental toxins or chemicals, pollutants, and so on. They have a very diverse range of types of studies with different strengths, different weaknesses. And the important exercise is not so much looking at the per study assessment of risk of bias, but about looking at the evidence together and looking at whether the directions of the biases actually still are compatible with a particular hypotheses about how things work. And the idea of triangulating across different studies with different biases is really quite important in this area. So that brings me pretty much to an end. Just to summarize, Robbins-E is on its way for systematic reviews that address PACO questions with our participants' exposures, comparisons of exposures and outcomes in reviews around issues of causality of disease or etiology. It's like Robbins-I, a detailed, comprehensive framework that will not be very easy to use, but it will certainly get to the biases that might threaten observational studies in this area. We'll have 7 domains, each with signaling questions. The initial version, which we hope will be out early next year, will address follow-up studies or cohort studies, and we're working on tools for other designs to go along with that. Thank you very much.
Thank you very much, Julian. This is Karen.
Hi, Karen.
Hey, and thank you very much for pitch hitting and joining us from the UK. I would ask that people, I guess, raise their hands and or enter some questions in chat if you have any questions, and we have received a couple. But I just wanted to make a quick comment / question. Having served on a number of National Academy and currently serving on National Academies panels reviewing EPA, IRIS, and TSCA processes for doing these sorts of evaluations, I can say that this tool is sorely needed, and I applaud the efforts. One of the things in those evaluations that we've noticed is the conflating, which you talked a little bit about, of different aspects. So reporting quality, applicability. I wondered if you could talk a little bit more about any discussions you had with the group about how to deal with those other related but not risk of bias aspects.
Indeed, indeed. So we haven't talked a great deal about reporting. I think we probably all understand that we have for a long time that reporting is an obstacle to assessment, but it's the truth that we're trying to get at. And so we're not targeting reporting clearly, as none of our tools do. The issues of applicability, they're really interesting. And one of the long discussions we've had over the years is the notion a lot of people like to think about is study sensitivity, which is the ability of a study to determine whether some substance is hazardous and how much. And if you think it through, it turns out that really is a combination of some issues of risk of bias and some issues of applicability. And we've tried to draw a very clear line between those. And indeed, at once, we currently have some optional questions at the start of the tool that get at the applicability issues, because people like to make sure that they're addressed in the same sort of place, but they don't feature in the actual risk of bias. So I'm talking about things like how long the exposure was, or how long after exposure an outcome might occur, or what doses of exposure have been studied. None of these things, if you understand what the studies are doing, are issues of bias, but they're issues of whether you can actually learn anything useful from those studies, which people do capture as study sensitivity.
Great, thanks. So there are a number of questions. I don't think we're going to get to all of them, but one maybe quick one that a couple of people have asked. Can you speak to when this tool might be available, even if for beta or pilot testing?
I'd rather not.
Okay.
As I say, I hope the first half of next year, but we keep saying something and it's proving incredibly difficult. I mean, some of us are, Jonathan in particular, who's key to this, has been very, very heavily involved in COVID-19 work, and we've not been able to progress very quickly.
Great. And then Celia, just I guess a pragmatic question. If we have additional questions that we don't have time to address, can we send those to the speakers, or what's the plan there?
Yeah, I think that sounds like a great plan.
Great.
Yeah, I'm sure the speakers would be happy to have a little discussion on chat. We would ask that you would keep your questions. If you're going to have an ongoing conversation in the chat, it would be great if you could do so in a private chat so that we can keep the wider meeting chat open for questions for the current presentation. And also to everyone who's attending, if you would like the email address for the speaker, feel free to ask me, send me an email, and I will ask them for permission to give out their contact info, and then we can connect you too. So thank you very much for that presentation, Julian. And up next, we are going to be hearing from Jennifer Lin and Helen Wu. Jennifer and Helen, are you both there? We heard you earlier.
I'm here. Can you hear me?
We can. Great.
Great. Wonderful.
Feel free to start when you're ready.
Great. First, thanks to the meeting organizers for creating this opportunity to share our work and all these other great pieces of work more broadly. Today, Helen and I are going to present to you the application of a conceptual framework that uses using systematic reviews supplemented with internal health system data to inform guideline development. So next slide, please. So neither of us have any conflicts to disclose. I do want to say that the framework presented today was funded by an AHRQ contract to support EPC work. Next slide, please. And our aim today for this very brief presentation is simply to articulate a framework for using health system data, which often goes unpublished, alongside systematic reviews to inform guideline development, which I will speak to for the first half, and then to explore a little bit on a high level its application within the Kaiser Permanente guideline program, which Helen will speak to in the second half. Next slide. So the framework that I'm going to highlight today is described here in detail. It was published earlier this year in JGIM, and a full report is also available if you're interested on the AHRQ EPC website. So I just want to acknowledge my collaborators. This work was a collaborative effort that represented the consensus opinion based on the collective experience of 5 different EPCs in the VA Evidence Synthesis Program, as well as a narrative review of the literature for guidance around this topic and related issues, as well as examples using unpublished health system data with systematic reviews to support health system decision-making, not necessarily specific to guideline development. And next slide. So briefly, I just want to frame the problem which underpins this framework, which is that systematic reviews are often a necessary but not a sufficient source of information for health system decision-making for a variety of reasons, which we call out in the paper, including the fact that often review findings are not really clinically actionable. That is, the reviews often find insufficient or low certainty evidence. However, a clinical decision needs to be made nonetheless by a health system or by clinicians. It's often unclear sometimes the applicability of findings in the included research to local practice. I think that's a common one. And then reviews focus on the evidence around the effectiveness and harms of a given clinical service or intervention, which is only part of the evidence or information that's needed to effectively implement a clinical service in practice. So next slide. So in this framework, we make 2 main points, and there is more detail in the paper if you're interested. And the first point is simply to be transparent about the purpose for using health system data, not to simply use health system data just because you can. And there are examples of this that we encountered in the literature. So this slide frames the three main scenarios when adding health system data may be useful alongside systematic reviews to either incorporate in the review itself, which arguably requires more resource and coordination, or used in addition to the review findings. So the first is to improve the strength of evidence. For example, adding data and analyses may address methodologic limitations in the published included studies, improve precision of findings. They may also address longer term follow-up or important outcomes that aren't otherwise addressed in the included studies in a review. Second, examining health system data can be used to determine the applicability of the review findings to the local population. In these scenarios, unpublished data, for example, may help health systems determine if and in whom to apply the review findings, for example, by knowing the absolute risk reduction or risk increase in their own populations. And third, and importantly, health system data can be used to aid in the implementation of a given service. For example, included studies in a review may not provide the information or data needed for actual replication or adaptation of an intervention into a given health setting. And important contextual information on patient values and preferences, feasibility and acceptability, or information on health system relevant inputs into cost effectiveness analyses, for example, their local prevalence, adherence, and cost data. And local health system data may also inform who and where to target the implementation. So which populations within their health systems, which sites. So next slide, please. So in addition to being transparent about how and when health system data can be helpful, it's equally as important to note some of the considerations and limitations for using this approach. And that's the second main point that we make in the framework. So I think it's important that while formal critical appraisal tools are very good, and it's important to apply this to unpublished work as well as published work, which I think we all agree upon, I think it's important to realize that many of these critical appraisal tools may not be robust enough to really understand some of the limitations of real world data. And I'm using that term loosely to refer to data not collected for research purposes. And so we advocate for basically working with health systems information staff or health system researchers to both vetting both the information quality as well as the data quality. And information quality referring to the extent which the data source can answer the question being asked, how well it reflects the PICO, and the data quality, of course, has to do with more the integrity of the data. And oftentimes understanding some of the data integrity does require working with people who know the data intimately. So I'm going to turn it over to Helen.
Thanks. Next slide, please. Okay, so I'm going to transition to talking about how we've used this conceptual framework in the Kaiser Permanente healthcare delivery system, where we do have a national guideline program and we maintain a set of guidelines on selected topics. So just briefly, our methods for developing these guidelines include drawing from existing high quality external guidelines and systematic reviews. Wherever they're available, we will critically appraise that work to ensure that it's high quality and applied grade to build our recommendations. We do have some capacity to conduct internal analysis using KP data for topics that we deem to be high priority that aren't well addressed elsewhere, whether it's in individual studies or systematic reviews or other guidelines. But we do seek to avoid duplication of effort and really focus, if we're gonna put some work into internal analysis, focus on issues that are uniquely important within the KP health system, where we think we need to get an answer that's kind of unique within our population of Kaiser Permanente members. Moreover, with internal analysis, we also want to emphasize the importance of maintaining some quality standards for the transparency of how that's done. When you have internally conducted work, it may not be written up in the same manner as, say, a peer-reviewed publication, which means that the methods and limitations might not be documented in kind of the explicit manner that you want to see. So looking to maintain some of those basic standards so that we can ensure the analysis was done well, even if it is not written up in the way of a peer-reviewed publication. What's really unique about working within Kaiser Permanente to build these guidelines is that we work hand in hand with the clinical leaders who bring insights about where the gaps lie between what is said in the external guidelines or the systematic reviews and the types of answers that clinicians really need. Next slide, please. So I have an example here where our clinical leaders for the Kaiser Permanente National Diabetes Guideline identified several topics recently that they felt were good candidates to prioritize for doing some internal analysis with our own data, because available guidelines and evidence, including both systematic reviews or even individual studies, just didn't quite address the questions that we needed to have answered in our clinical guidance. So we used the conceptual framework to think through how internal data could strengthen our guideline, and what we added to that was also feasibility considerations. So for example, do we have the data that we need to answer those questions? Since this was looking at some drug treatment topics, is there variation in the formulary for some of these treatments across Kaiser Permanente, which is actually in eight states and DC, that would complicate an analysis of specific drugs because of differences in the drugs that are being used across our system. How long would it take to see the outcome of interest? Because some of the questions were for newer treatments. So the analysis would need to be prospective to get what we needed. And then do we have the sample size and power to detect the outcome of interest? So we have a very large population of members. There are 12.3 million members in the Kaiser Permanente system. So that's a lot to work from, but when you start sort of getting into specific drug combinations, that can still be hard. So the first topic, which we deemed to be the most feasible that we're starting to move forward with now, was on the cost effectiveness of diabetes treatments. So there are many different treatments for diabetes. Some of them are much more expensive than others, and their effectiveness might be only marginally better than some low-cost options. So knowing how these compare in a cost effectiveness analysis would help us apply grade and considering the resource implications better to develop recommendations. But external guidelines didn't really address this cost effectiveness trade-off very well. And external CEA studies, if we did have any, would not necessarily be right or generalizable to our delivery system, since Kaiser Permanente encompasses a health plan and a healthcare delivery system. So our cost structure is different. So the answer might be different. So this topic felt like a good candidate due to its ability to improve our implementation, thinking about the conceptual framework. The second topic was third step therapy. So this is the notion that when people with diabetes aren't responding well to the first drug, you put them on, you add a second, and they still might not be responding well, so you want to add a third treatment. And the trouble with this is we wanted to structure our recommendations in this way, like what is the third thing that you would try for folks who aren't responding well? But the evidence doesn't explicitly report on outcomes when they're used in this way. So they might be used as kind of a first or a second step treatment, but not a third one. So it's kind of a unique combination in how the treatment is delivered. And the evidence that we had to apply in writing our recommendation on this was very indirect. So having some data that we could draw from our own health system would make the content more applicable so that the evidence would be more direct. This topic we felt might run into some feasibility issues, because when you do start getting into specific combinations of drugs, you might run into some sample size issues for having adequate power. And then quickly, kind of the last two have to do with newer drugs, SGLT2s and GLP-1. So these are some newer treatments for diabetes. We have limited evidence about their benefit, especially if they're used as, say, second line treatments. We don't have head-to-head trials to have direct evidence for the way that we're using them and for the way that we have them written into our guideline. So looking to get some more information that sort of matches up with how our guideline recommendation is written. Feasibility is tough for both of these. Long-term harms is the last one that refers to the same class of drugs. So we have some data from existing studies that have tracked harms of these treatments for up to 5 years. We'd like to see longer-term data, but we would have to do that prospectively because they're new drugs. So we don't have a long track record of that in our system. So we'd have to look forward, which would be a harder feasibility issue for us to deal with. So to summarize, we found all of the 3 criteria in the framework, implementation, applicability, and strength, useful in evaluating what an internal analysis would add for these topics. But what we added on there was the feasibility considerations, which helped us to narrow it down and prioritize and sort of identify cost effectiveness as the top one to work on further. Next slide. that's a wrap on our end. So we have a little time for questions and discussion.
Thank you very much, Helen and Jennifer. This is Karen. So I'd ask that people send any questions they might have in the chat. I'm not sure that I would see a hand raised, but you could certainly try to do that as well. So please send any questions in chat, and I will ask the first question anyway. Not to completely get back into the discussion about insufficient evidence that we had yesterday during the EPC meeting, but Jennifer, I guess, I was struck by there was a title in one of your slides about integrating the healthcare data into the systematic review. So I wonder if you can talk a little bit about the timing of when you would apply this proposed framework that you presented, at what point it would come into play.
Great question, Karen. And so I would say the short answer is for interested people, please, read the manuscript. We do talk a little bit more about just process-wise where this fits into a life cycle review, health system data informing, really the scoping of a review, being integrated during the actual conduct of the review. So it has to be conducted, in tandem basically, which is, again, requires a lot more coordination and resource and collaboration with actual, primary researchers, as well as what we call a data appendage, sort of tacking it on at the end, of a systematic review or done, by a separate group. And we have some examples of I think pretty eloquent, well done examples of people who've done those sorts of work at the different phases of review. What we don't address very well is, and it's sort of left for future research, future considerations, is really what an infrastructure would look like to make this happen more than just like a one-off or every once in a while, in terms of, really incorporating it and leveraging, a learning health system's ability to incorporate unpublished or their own data analyses with, external reviews or even internal reviews that they're conducting for themselves. So I think, to your point, I think, if this is something that's worthwhile, and I think many of us who worked on this framework thought it was, we don't address some of the infrastructure concerns about actually doing that. But I encourage folks, if they are interested, to look at the paper examples. The VA ESP has a very eloquent example in there, and maybe querying their process and their program as to how they actually made that happen in real time.
Great. Thank you.
Great. Well, thank you. That brings us to time. So I think we are going to transition to our next presentation. Up next, we will be hearing from Mary Razga. Mary, go right ahead.
Great, thanks, Celia. I'm Mary Razga. I'm a registered dietitian from the Academy of Nutrition and Dietetics, and I'm going to discuss a systematic review that we recently conducted examining the effect of nutrition therapy to reduce hyperphosphatemia in individuals with chronic kidney disease. And in particular, I'm going to focus on a methods question that we addressed within the context of this systematic review. And that was, for clinical nutrition research questions, is it worth our time to include non-randomized controlled trials in addition to randomized controlled trials, or RCTs? So I'm employed with the Academy of Nutrition and Dietetics, but I have no other conflicts of interest to disclose. So just to give you a little bit of background on the topic area, individuals who have chronic kidney disease are at risk of having elevated serum phosphate levels or hyperphosphatemia, and this can increase risk for adverse health outcomes such as CKD, mineral and bone disorder, and cardiovascular diseases. So for nutrition interventions, just like any healthcare intervention, the efficacy is best tested within the context of a randomized control trial. But we conduct a lot of systematic reviews on nutrition topics on our team, and RCTs are often lacking. So nutrition interventions can take a long time to affect these health outcomes that we're interested in. Also, the experiences that a participant might have in the context of an RCT might not be applicable to their everyday life when we're trying to modify lifestyle behaviors like diet, where the individual will have to make multiple choices about their diet throughout the day. So because we're a practice-based organization, we really, though we want to focus on the highest quality evidence, we also, if that's not available, want to go to the next best thing so that we can offer our practitioners the best available evidence. So our objectives were twofold. For our methods question, we wanted to see if the effect size or the certainty of evidence would change according to if we included RCTs only or RCTs and non-randomized control trials. And then of course we wanted to answer our PICO question. So our question was, in individuals with CKD, what is the effect of phosphate-specific nutrition therapy provided by a registered dietitian or international equivalent compared to usual care on phosphate levels? And we included all controlled trials. They didn't have to be randomized, so quasi-experimental trials were okay. We conducted a literature search of Medline, Embase, and multiple other databases for literature published from 2000 to November 2019. And for risk of bias assessment, we used the ROB 2.0 tool for RCTs and the Robbins I tool for non-RCTs. To answer our research question, we stratified meta-analysis by study design, and then we also stratified quality of evidence by study design. Our databases search identified over 5,600 articles. We reviewed the full text of 168 articles, and there were 13 studies included in the systematic review, 11 RCTs and just 2 non-RCTs. And of these 13, 11 were included in meta-analysis. So here's our forest plot for the meta-analysis of the 11 studies that we could use their quantitative data. You can see here's the no effect line, and all of the studies had a similar direction, so that participants who received phosphate-specific nutrition therapy from a dietitian had lower serum phosphate levels compared to the control group. So the overall effect size was a decrease in 0.77 milligrams per deciliter. And the RCTs are right here, and you can see almost an identical effect size, which we would expect, and moderate heterogeneity. So the I-squared value is 63%. We just had one non-RCT in quantitative analysis, and the effect size was really very similar, but the confidence interval was wider. And the 2 RCTs that weren't included in the meta-analysis were very similar. Both showed a reduction in serum phosphate levels compared to the control group. It wasn't significant in the RCT, and it was significant in the non-RCT. So what did these studies look like? The figure on the left here is the risk of bias assessment from the ROB 2.0 tool for our RCTs. And you can see there was some consistent sources of bias from the randomization process and deviations from the intended interventions or lack of information about those factors. So overall, all of our RCTs had either high or some concerns of risk of bias. And then on the right is the risk of bias from the Robbins I tool for the non-RCTs. And again, we have some consistent sources of risk of bias, including from confounding, but very similar, the overall quality was serious or moderate risk of bias. Here's our summary of findings table. This top row of results is for the RCTs, and the bottom one is for the non-RCTs. We already talked about effect size. We had about 1,100 participants in the RCTs and 158 for the non-RCTs. We started both of them off at high for certainty of evidence because we used the Robbins I tool for the non-RCTs. That limitation was already worked into the risk of bias assessment. So each of them were marked down for risk of bias. The RCTs were additionally marked down for that heterogeneity that we saw, and the non-RCTs were marked down for lack of precision due to small sample size. So I think one could argue that maybe this should be moderate and shouldn't have been marked down for the heterogeneity, but the take-home message is the same, that even when we were conservative, the RCTs were at least as high or likely higher than the non-RCTs. So we came to the same conclusion from both of the study designs, that the evidence suggested that phosphate-focused diet therapy from a dietitian did reduce serum phosphate levels. our major limitation was just the lack of non-RCTs that were available to compare to the RCTs. So for this specific nutrition clinical question, our conclusion was that the overall effect size and certainty of evidence were not notably affected by including or excluding non-RCTs. And we definitely recognize this is a limited example. For this project, we also had another question that we asked where we included both study designs, and the outcome was the same. The results were the same, but the quality or the certainty of evidence was higher for the randomized trials. So our conclusion is really that it's advantageous to try to do your homework and do a scoping review prior to the systematic review. We've really come to depend on these when planning our eligibility criteria. So if you can identify what you would consider an adequate number of RCTs in the scoping review, for me, for a question like this, it may be 7 or so, or 10. Then just focusing on those RCTs. But if they're not available, then bringing in those non-RCTs too, because it did, in our study, they did have similar results. So in this question, we wanted to examine control trials specifically, but that's not to discount the potential added information that we could get from cohort studies that can capture these long-term health outcomes that we're interested in. So just based on what we found and thoughts about the future research, we just put a quick algorithm up here. It's important to do a scoping review, and if RCTs are available, just focusing on those. And then if they don't report health outcomes, then thinking about incorporating these cohort studies with that. And then similarly, if the RCTs aren't available, then going to those non-RCTs, since they, hopefully will have a similar direction and strength of evidence if you use the right risk of bias tool. And then again, incorporating the cohort studies if those control trials don't report the health outcomes. So I think we have time for questions, and I'm happy to take some.
Yeah, that's great. Thank you very much, Mary.
Yeah.
I would ask people to, again, put their questions in the chat so I can convey that to Mary. And I have a few questions, so I'll at least get us started. I think that a number of us might include different sorts of study designs as non-RCTs. And I'm particularly confused then when you had, at your last slide, include non-RCTs and cohort studies as though they weren't included in the same category. So maybe could you define what you meant by non-RCTs?
Sure. So for this question, we were interested in controlled trials. So it had to have a control group to compare to. It could have been in a real world setting where they did a quasi-experimental trial, but they did have to have a control group. So we were looking at non-randomized versus randomized controlled trials. So they were all controlled trials. This wouldn't be for every question. We ask some nutrition questions that are more kind of exposure based, but for certain questions that were about a clinical intervention, we really wanted to focus on the controlled trials for this question. But then also recognizing that there are some studies that could track people in their dialysis unit, for example, over time, and look at the effect of a dietitian that way, and maybe we could add some value to our control trials from those kind of studies.
Great, thank you. So I have one question here from Jonathan Treadwell. For the search, did you try to quantify how many abstracts you'd have to sift through if you had required RCTs at the search level? So I think
that's a great question. For this one, I don't think we've done that, but we have done that for other questions. And it is always kind of weighting the effort that we'll have to go into plus versus what we'll get out. A lot of times we always use expert panel work groups, and they're very passionate and they want to include everything that they can. So a lot of times we will do this two-tiered search where we're trying to encourage them to go towards the high quality data, but if they really know of trials that they know are important to include and they want to open it up to those non-randomized, we'll kind of compare if it seems like we can take on that extra effort for the screening.
Great. And any other questions?
Great, thank you.
Thank you.
Yeah, thank you so much, Mary. All right, everyone, up next, now we have a little bit of a break and we are running a smidge ahead of schedule. So we will reconvene with our content at 12:35 p.m. Eastern. Elizabeth, do you want to share our break slide? And in just a few moments, we will be doing a speaker mic check for our next session. So Rasmus, Carol, Lee, and Aditi. Yeah, so everyone, quick break. We will be back at 12:35 Eastern. All right. So Orestes, Carol, Lee, and Aditi, would you all just try to unmute yourself and just say here to let us know that your microphone is working all right?
Hi, Sonia.
Hi, can you hear me?
Hi, Sonia.
All right.
Hi, Celia. How are you?
I'm doing well. I'm doing well. We can hear you all just fine. So we've got about another minute, and then we will get started with Orestes. Thank you. Okay, all right. Up next, we will be hearing from Orestes. Orestes, you should be able to start sharing your screen from the bottom. Wonderful, and we can see your slides. You can go ahead and get started. Thank you.
Thanks for inviting me here today. I know we don't have much time, so I may be rushing over some slides. I'm happy to take questions at the end, or if you have any thoughts and comments, you feel free to email them to me. So I'm going to present a project that I have been working with Ruth Heller, Iman Zalzouli, and Yoav Benjamini from University of Tel Aviv, which tries to recast meta-analysis within the simultaneous inference framework. And we're using this approach to estimate and evaluate replicability of treatment effects in a meta-analysis. I would like to acknowledge funding from AHRQ that has been supporting this work for the past couple of years. And I'll start by trying very briefly to summarize why we care about replicability of treatment effects and why we may need to know whether more than one or more than two studies in a meta-analysis finds a treatment effect. All this goes back to FDA requirements as well as everything that we know about the importance of replication and replicability. Essentially, having evidence towards this direction protects us from systematic biases, minimizes the role of chance, and makes the results less likely to be dependent on a single study, which may be different because of populations, interventions, or other characteristics. So what the FDA asks when someone submits an application for a new drug is whether at least two studies have found an effect, and if the effect is replicated, or alternatively, if the effect is replicated in at least two studies. There are many approaches, I would say, to do this when there are only two studies that evaluate the treatment effect. The simplest would be to establish the union hypothesis that each study rejects the null, and then take the p-value or the maximum p-value of these two individual studies. But things get a little bit more complicated when we operate in the meta-analytical setting where we have more than two studies. So the work that we're trying to do in this setting aims to expand what happens in the two-study setting. And essentially, when we have a meta-analysis, what one can do is try to run a fixed or random effects model, estimate the summary estimate, and then see whether this rejects the null. But the case is very often that we end up rejecting the null only because we combine multiple studies and we increase statistical power without really having evidence that the treatment effect is replicated in two studies. The extreme would be to require that each and every single study in a meta-analysis rejects the null, and then in this case we have multiple p-values from each study. We take the maximum and we can evaluate the union hypothesis. But somewhere in between lies the framework that we're developing, which is whether the treatment effect is found in some but not all studies. So the hypothesis we're trying to build is answering the question whether the treatment effect is established in at least U, a pre-specified number U of n studies in a meta-analysis. And we test the null hypothesis that at least U of the component or individual null hypothesis hold true against the alternative that at least U are false. And in order to do that, what we need is to develop a test statistics for testing these hypotheses. So I'll give some more background based on the slide that I showed earlier. So the typical fixed effect meta-analysis tests the conjunction hypothesis that the treatment effect is null in each of the individual studies, and it can be rejected even if one study ends up rejecting the null. The disjunction hypothesis is the one that the null hypothesis is rejected simultaneously in each study. So each of them has to find an effect. And our framework, which addresses whether at least some studies, but not all of them, simultaneously reject the null, uses the partial conjunction null hypothesis framework. So I'll skip the details, which you can find in a paper that we have in arXiv. So essentially, what the hypothesis that we're building and testing is this composite that you see here, that at least U-1 studies have an effect in its direction. And this is something that we operationalize as the intersection hypothesis. And there is work from Benjamini's group and Ruth Heller over years that tried to provide p-values for these hypotheses. And the p-value that we're using is what we call the R value, which is twice the minimum for the R value for the right side alternative and the left side alternative. And again, I'm not going into the technical details because of time, but essentially we run this one-sided and one-sided for the right alternative and one-sided for the left alternative for all possible subsets. And then we take the p-values, and from this vector, we take the minimum. So we say that the treatment effect is replicable if the R value that we compute in this way ends up being less than the type 1 error rate, which typically is 5%. So the test statistic that Iman, who is a PhD student in Israel, has identified as the most powerful one is a modified version of the truncated Pearson statistic. Again, I'm not going to go into the technical details because of time, but it all comes down to this Pearson statistic that is shown in the bottom. One additional thing that we compute as a byproduct of the previous steps is the maximum number of studies for which the replicability is rejected. And this can be seen as a lower bound on the studies that have effect in the same direction. So this tells us among the studies in a meta-analysis, what is the minimum number of studies that one could potentially remove from the meta-analysis without changing the direction of the effect. And this is the paper that we have in arXiv, and I'm happy to send the link or preprints. We'd really like some input about the applicability of this method from meta-analysts who might think about using it. So it's not so much the technical stuff that people might be interested in, but really how this can help the field move forward, and what does this evidence of replicability tells us about evidence quality. So in the next few slides, I'll show some results from a preliminary analysis that we did in Cochrane. We identified all meta-analysis of binary outcomes with at least 5 studies, and we tried to identify how many of those have evidence of replicability. At the end of the day, we identified over 23,000 distinct meta-analyses with more than 200,050 RCTs. And when we applied the previous approach for meta-analyses that were done either using a fixed effect or a random effects model, we found that replicability was not met in almost 70% of the meta-analyses overall. And among those meta-analyses that were statistically significant themselves, replicability was not met in almost 40%. In terms of number of studies in each meta-analysis that have effect in the same direction. The median was 3, and it ranged in terms of interquartile range from 1 to 5, and that is the overall number. And if you try to normalize this to some extent by computing what is this number over the number of studies in a meta-analysis, then we find that across all meta-analyses, the median number of trials that had effect in the same direction was 33%. And we compute this number as a percentage because if you think of a meta-analysis that has of 2 different meta-analyses, one might have 10 studies, the other may have 20 studies. This number might tell you something different if the number of studies that find effect in the same direction is 5. This has a different meaning in a meta-analysis of 10 studies versus a meta-analysis of 20 studies. And again, this is very user-specific and field-specific, I would say, but it helps us at least make some inferences about the robustness of evidence, generally speaking, and how this can be used in frameworks that evaluate strength of evidence or quality of evidence. The next couple of slides focus on the subset of studies or subset of meta-analyses that had found statistically significant results. Here, among those studies, among those meta-analyses, the median number of studies that found effect in the same direction was even smaller. It was 2. And when we normalize this over the number of studies in each meta-analysis, that number becomes 25%. So these are the slides that I had created. I try to stay within the 10-minute framework or time framework. I'm not sure how better we have some discussion around it.
Wonderful, Orestes, thank you. Now we have a few minutes for questions in this upcoming session. I'm sorry I did not introduce her before, but Dr. Christine Chang will be moderating this.
Great, thank you so much, Orestes, for this interesting presentation. Obviously, you've skimmed over some details that were very complicated for us, and given us a high-level overview for those of us who are not intimately acquainted with some of the analyses. I was just wondering if, as you looked at your the results of looking at the Cochrane meta-analysis, if you did any sub-analysis to see if there are any differences among the different kinds of reports, whether by topic or other factors. You're on mute.
My Zoom crashed for a couple of seconds. Can you repeat your question? I'm sorry about that.
I was wondering if when you were doing your analysis of the different meta-analyses, if you looked at any factors that could have contributed to replicability or a lack of replicability.
Yeah, that's a great point, and I didn't show these numbers, but actually we're trying to associate or correlate other meta-analytic diagnostics such as heterogeneity, publication bias, excess significance bias, these type of tests. Interestingly, we don't find that publication bias is correlated with a lack of replicability, which was surprising. What we see is that heterogeneity tends to correlate relatively well in instances where we don't have heterogeneity. It's less likely that we're going to have lack of replicability. And we believe that these two statistics can complement one another, because one issue that we have been having is what do these things really tell us that is different and distinct in these cases. The third thing that we're looking at has to do with whether there are types of biases in specific studies that have to do with blinding or allocation concealment, because in most of the cases we can tell which are those studies that drive the meta-analysis and maybe can be considered extreme cases or extreme studies. So once we find them and we remove them, quote unquote, remove them from the meta-analysis, we planning to go in and try to see whether these are studies that may be different because of blinding or other biases. And this builds on work that Jonathan Sterner has done, where he identified some domains that are really more likely to affect the treatment effects.
Great, thanks. I'd encourage people to put questions in the chat, or if you would like to raise your hand and ask a question, please feel free. I just see one comment in the chat saying this is very interesting.
Yeah, and thank you, Orestes. I think that brings us just about to time. So I think we can go ahead and get on to our next presenter. Up next, we will be hearing from Carol Lunny. Carol, do you want to start sharing your screen?
Hi, yes, I will. So just a minute. Great. Well, thank you very much for inviting me. And I'm on behalf of my co-authors, I'd like to present a methodological review of items for assessing bias in network meta-analysis, which will provide the groundwork for the development for a new risk of bias tool for network meta-analysis. So I'm a postdoctoral researcher at the University of British Columbia, but I'm working with various universities and organizations, and I'd welcome anybody emailing me about our research. So first of all, I'd like to acknowledge the land in Vancouver, BC, on which this research is conducted. For thousands of years, it's been the traditional, ancestral, and unceded territory of the Musqueam, Squamish, Stalo, and Tsleil-Waututh nations, and we have no actual or potential conflicts of interest in relation to this presentation. So in this section, I'll be introducing you to our project team. I'll be outlining various quality assessment tools, and I'll be providing the rationale for our risk of bias tool for network meta-analysis. I'll go over the 3 stages of development and talk about our methodological review of bias items for network meta-analysis. And then I'll discuss future steps. So our project team consists of the steering committee, which is myself, Andrea Trico, Brian Hutton, Argy Veroniki, who will be talking later, Georgia Salanti, Julian Higgins, Ian White, Sophia Diaz, and Penny Whiting. We also are working with several students and an international group of stakeholders who will help us in our dissemination efforts. So a structured quality assessment tool provides a standardized way to assess quality, providing consistency across reviews. Many tools and checklists can be used for systematic reviews with pairwise meta-analysis or for narrative summary as well. Namely, 60 checklists can be used to assess how well a study's been described, or we can say reported. 40 are available to assess the quality of conduct of a systematic review. And 1 can be used to assess the risk of bias in the conclusions of a review with pairwise meta-analysis. And a bias assessment is an assessment of review limitations which focus on the potential of those methods to bias the review findings or the review conclusions. So this table shows tools and checklists to aid in systematic review conduct or to assess the reporting or methodological quality of a review. So in this middle column, we see examples of tools or checklists for reviews with narrative summary or pairwise meta-analysis. And in the right-hand column, we see tools or checklists for network meta-analyses. So for example, to assess the quality of conduct in reviews with pairwise meta-analysis, authors could use the AmStar2 tool or the OQAC tool. And for network meta-analysis, they can use the International Society for Pharmacoeconomics and Outcomes Research tool called the iSpore tool. or to assess the risk of bias in published reviews, the robust tool could be used. However, there's currently no tool to assess the risk of bias in reviews with network meta-analysis. So what's the rationale for the development of a risk of bias tool for network meta-analysis? So first, audits of network meta-analyses have found that their quality is subpar. In a survey of 438 network meta-analyses, we find that 75% were considered moderate to low quality based on AmStar, and 50% were inadequately reported. They inadequately reported 6 iSpore network meta-analysis items. Second, novel elements in the network meta-analyses require a bias assessment tool tailored to them. So for example, here, the choice of node-making method, for example, splitting or lumping of interventions, can drastically alter the network and subsequent network meta-analysis results. And third, many reviews with network meta-analysis are published on the same topic with conflicting conclusions. For example, one study identified 28 network meta-analyses on rheumatoid arthritis. So choosing a high-quality network meta-analysis from multiple conflicting NMAs is difficult without a tailored risk of bias tool. So our tool will address the degree to which the methods lead to a risk of bias in the review conclusions. The 3 stages of tool development are aligned with our objectives, which are to first conduct a methodological review to develop a list of items relating to risk of bias in network meta-analyses. Secondly, to conduct a multi-round Delphi process to solicit expert opinion on the inclusion of items. And finally, to pilot test and then refine the tool with different user groups. So a comprehensive and systematic process will be used to develop the tool as outlined in Penny Whiting's framework for developing quality assessment tools. So starting with the methods in our methodological review, our eligibility criteria were reports such as journal articles, guidance documents, or book chapters that describe items or criteria used to assess the bias or quality in reviews with network meta-analysis. We extracted data on items that are potentially relevant to the bias or quality of reviews with NMA, and we extracted data on items that are potentially relevant to bias or quality, and then, items were extracted and analyzed by 2 authors independently. And for the data analysis, we grouped items into domains by similar concept. We split items so that each covers a single concept. We classified items as relating to bias or other aspects of quality. And then items were reworded as signaling questions. So for our preliminary results, we included 56 studies which fall under these categories: tools, methods, guidance, and quality assessments for NMAs. We also included the updated PRISMA guidance for systematic reviews with pairwise meta-analysis. So we haven't quite finished data extraction, and when we're done, we'll have a list of retained items which will be refined by the steering group. A final list of items will be compiled into a domain-based tool. In our next 2 stages, we'll conduct a multi-round Delphi process to solicit expert opinion on what items should be included. We will invite a sample of 50 experts, and we have defined consensus as 70% agreement. We'll then pilot test the tool and refine it based on our results. And we are also in the process of developing a knowledge translation strategy, which will include training knowledge users in how to use our tool. So I thank you for your attention, and I welcome any questions.
Okay, thank you so much, Carol. We have one question from Roger Chow asking, the distinctiveness of this new tool and what it adds over other available tools.
Yes,
yeah,
so
go ahead. Yeah.
Oh, sorry, just to expand on this, I had a similar comment earlier with the Robbins E proposed tool, and I have a concern about just this proliferation of, you know, more and more tools for assessing risk of bias. And it seems like many of the issues with network, there are unique issues with network meta-analysis, but many issues are overlap with doing any other meta-analysis. And it seems like just like we can assess cluster RCTs and crossover RCTs with, you know, relatively, you know, minor modifications of our RCT risk of bias tools, you know, why wouldn't we use a similar approach here instead of coming up with an entire new tool?
Thank you very much, Roger. That's a great question. So I've kind of created this table to give like an idea of the different tools that have already been developed for network meta-analysis, and also the tools for reviews with pairwise meta-analysis. And you're right, like a lot of the process that's going to be happening in a review with network meta-analysis will be similar. I mean, all of the systematic, you know, eligibility, description of eligibility criteria, going through selecting studies, extracting data, assessment of risk of bias of the included primary studies, all of that will be similar. However, the analysis section will be significantly different. And there are some aspects of those other domains which will also be different, taking into account the transitivity assumptions and other assumptions in network meta-analysis, which are different than systematic reviews. The other thing that will be different is that there's currently no tool to assess risk of bias. Currently, there's only the ROBUST tool to assess risk of bias in reviews with pairwise meta-analysis. And it's very different from a tool such as AMSTAR2 or OQAC, which are designed to look at the quality of conduct. It's not specific. It doesn't specifically look at the biases that it introduced when a systematic review is finally published and developed. Those biases are very different than primary study biases, as you all very well know. In addition, I'll just have a slide at the end here, which I've put together, which kind of gives examples of biases in network meta-analysis, which are very different than biases in a systematic review with pairwise meta-analysis. So here, the one example that I have at the top is node splitting bias. So a bias it gets introduced if there's different ways that you can do things that result in a different treatment effect. So here, different ways of node splitting can include broad lumping, where you would group similar interventions at a broad level. You could group interventions with similar PICO elements, for example, taking into account clinically important variables. You could do a lumping and dismantling approach, which could be informed by a meta-regression to investigate the effects attributed to different components. Or you could use a class effect model, basically, that lumps interventions together based on a drug class. So all of those, basically, if you don't report and if that is not informed by your objectives, and if it's not pre-specified, then bias could be introduced. This node splitting bias can be introduced in the network meta-analysis. Other examples could be rank probabilities can be biased as well if the uncertainty of some treatment effects is larger than others. So there is very specific biases inherent in network meta-analysis. You could think of a network meta-analysis as sort of a broader pairwise meta-analysis where more bias could be introduced because there's more treatment comparisons.
So I mean, I recognize, and I mean, we're very familiar with network meta-analyses, and there are specific issues. And I think the points that other folks have made also are important, that not all of these are biases per se. These are methodological differences and maybe, you know, different approaches to analysis. They're not necessarily biasing things, or at least not in a predictable way. So anyways, I think just urging the work group to, you know, again, my concern is there's dozens and dozens of these risk of bias assessment tools, and there seems to be more every, you know, year. And, you know, is there, you know, ways to be more focused and or, you know, consider this as an add-on to Prisma or whatever. I mean, I understand that the group has, I guess, certain approach they want to take, but I just urge some caution and you know, that we as a systematic reviewer not wanting to be drowning in all of these tools.
Yes, definitely. And you know, these days you have to be very informed about what tools are used for which purposes, because as you said, there's many tools, and how do you choose even between the tools? That's a challenge for most people.
Thanks, Carol. Just one question. I realize that this work is in process. What is the timing for your next steps? Debuting, you know, some details around this tool.
Yeah, so we are expecting to be finished our methodological review by January, and then we'll be launching the Delphi process because that work is already being kind of put together, which will be informed by our methodological review. However, if anybody is interested in being part of the Delphi, please email me because we're going to be asking for a sample of 50 participants, and hopefully we'll get that. I'm hoping.
Great. We'll get your contact information to share with interested folks.
Thanks.
Thanks so much.
Thank you, Carol. Up next, we will be hearing from Lee Wong. Lee, you can go ahead and start sharing your screen now.
Great, thank you. Can you see my screen?
Yes, we can.
Oh, great. So it's a great pleasure to meet you all virtually here. So my name is Lee Wang from the McMaster University. So we have done a lot of like the meta-analysis and systematic view of the prognostic studies. So, but we have been faced a lot of methodological challenges. This is one of them. How do we deal with the missing data when we do the meta-analysis of the prognostic studies, particularly because the missing due to non-significant. So I have no conflict of interest to disclose. So and our work was presented in this year's Cochrane program. So as we all know that, so many of the prognostic studies, they use the data-driven methods, or sometimes we call them reduced regression model. So they use either the bivariable analysis or univariable analysis to select the significant factors, then enter them into the final regression model. And the other prognostic studies, so when they report the data, like the adjusted data, they usually just only pick, sometimes they pick the significant factors, then by ignoring the non-significant one when they report adjusted data. So when we do the meta-analysis or systematic view, if we only consider including the adjusted data reported, by ignoring those data, excluded because non-significant, we might have a risk of overestimating of the association. That's why we did this work, try to explore the impact if we do the imputation for the missing non-significant data. So what's the impact on the overall association for all the risk factors? I used the two predictor view, the systematic view of prognostic studies as examples. One is a predictor of the persistent post-surgical pain after breast cancer surgery, which is published in CMAJ, the Canadian Medical Association Journal in 2016. The other one is a predictor of the unemployment after breast cancer surgery, just published in the Journal of Clinical Oncology in 2018. So we did the pooling analysis. So as a general prognostic study, the meta-analysis for it, we try to explore the association. So what's the significant or non-significant factors associated with persistent post-surgical pain or unemployment? We used a random effects model to do that. But we do have, as I said, we do have some like the missing non-significant predictors. How can we use that data? We did an imputation. We don't know the direction, either that's favor or in favor or not, the association. So we did the adjusted odds ratio equals 1 for these missing non-significant factors. And we imputed the associated variance using the hot deck approach. Then we compared, we call them primary analysis, which included all the reported adjusted data and the imputed data for the non-significant factors. And we did a sensitivity analysis by excluding the imputation, only keep those reported adjusted data, and we calculate the ratio of the odds ratio of the reported data versus the full set with the imputation. And based on our two predictor reviews, we include 56 studies, and among which we have 18 studies. They use the bivariable or univariable analysis to select only the significant factors. And among which we have about 70%, 38 studies that fail to represent all the data for, particularly for the non-significant predictors in the final adjusted model. And for the two predictors review, we pulled 27 predictors or risk factors, and we do have 3, then all the data was reported. So this is for our first predictor review for the persistent pain. We found 5 factors. So which means a younger age, so patients who had radiotherapy or had the axillary lymph nodes dissection, or have more severe acute post-operative pain or pre-operative pain. So they're highly associated with the persistent post-operative pain after breast cancer surgery. So we use a imputation, the whole primary analysis with imputed data and report data. We can say, let's take the age as example. We have 14 studies reported adjusted data for age associated with the pain, but we have 8 studies. So they are not significant. There was no adjusted data for it. We did imputation. Eventually, we included 22 studies. The pooled adjusted odds ratio is 1.36. But if we only use the report data, we'll see that actually the pooled estimate is 1.42. So that's why our ratio of odds ratio is 1.04. So for the other one, we can see that for all of them, the ratio of the ratio range from 1.04 to 1.15. We do have 4 factors we still put, but it's not significant or associated with the persistent pain after breast cancer surgery. And the ratio of odds ratio still ranging from 0.1 to 1.11. Particularly these factors, we can see the BMI. We only have 3 studies reported the adjusted odds ratio and associated 95 confidence interval. We put them, it's significant associated with a higher risk of the persistent post-surgery pain. But when we did the imputation for the 5 non-significant studies, so the pooled odds ratio become 1.11, but it can become non-significant. So the overall one from the 4 factors, we can see the ratio of odds ratio range from 1.01 to 1.11. We use the same idea for the predictor for the unemployment after breast cancer surgery. So so this is our adjusted data. And this our primary analysis include the imputed data for non-significant factors. We can see almost have the similar trend. So if we only consider the adjusted data, it's the association consistently larger than the unadjusted data. The ratio of odds ratio is from 1.04 to the 1.55. This predictor is particularly very large because it has the largest association. And after we added the imputation for the non-significant factors, they shrink a lot. That's why we get a largest ratio of odds ratio. So for the non-significant, we do have one factors that's still significant, but we did not do any imputation as all the data is reported. We do have 9 non-significant factors, then 2 predictors. All the data was reported, but you can still see the trend. So if we only use adjusted data, the pooled associations still consistent and larger than the unpooled, and then all the data set. So that's in summary. So we can say the ratio of odds ratio, if we only use the report data versus the full data with imputation, so it ranged from 1.01 to 1.55 among the two predictors we use. And so we can see that all the product association was larger in the meta-analysis, which only based on the report data, and which might exaggerate the magnitude of the association by 1% to 55%. So in conclusion, we will say the primary study, so those explore the prognostic factors often fail to report data for non-significant predictors, at least in our 2 reviews. So we have about 70% of the study that did not report all the non-significant factors. When we do the meta-analysis, if we only consider the reported adjusted data, and by ignoring the missing non-significant predictors, which might overestimate the pooled measure of the association. So that's why we recommend the best way is when we do the primary prognostic study, so we prefer all the authors report the adjusted data for no matter that's significant or not. When we do systematic review, we try to contact the author to get the missing data for non-significant factors as much as possible. If we could not, so we prefer to do, we encourage you to do the imputation to avoid overestimate the association. So thank you all very much. If you have any questions. I'm happy to take any questions.
Thank you so much. I'd invite folks to either ask a question or put something in the chat.
This is Roger. I made a comment and maybe I'll just ask it. So it seems like the effects would be totally dependent on your assumptions for the imputation. And so from my understanding, the assumption was that there's kind of no effect. Yeah. But it could be that the studies that weren't reported actually had similar results to the ones that were. They just weren't reported because they were not statistically significant. And if that's the case, then adding those studies would actually just give the same results but give you more precision. We just don't know is the problem. So unless you know what the and so like I said, I think it just seems to really depend on what your assumption is about what's going on with the non-reported studies.
Yeah, that's correct, actually, because as I said, we don't know, right? We don't know them because they did not report the data. We don't know the direction, either the similar as the other studies or not. Maybe go to the opposite direction. That's why we decide we use in the middle. We said, okay, we'll assume you said no, it means no. Neither favorite this direction, nor favorite that direction. You are right, if we know that, if we understand the data, may be similar, but may not, right? That's why we have made the assumption. We said we assume that's so the odds ratio equals 1. Neither favorite neither not in favor of the association or not, right? But that's a one. That's why we try to contact the author to get the missing data. That's the best way. But sometimes, yeah, we failed, right? We have to do some imputation. I guess this is to some degrees more conservative. To if they do have the similar association.
Yeah, thanks. And like I said, I think that this is an issue that we run into quite a bit. That the studies that are dropped from the model are never reported, so we just don't have that data. But like I said, I don't. This is a by using a imputed odds ratio of 1 for all those studies, you're automatically going to attenuate the estimates. I mean, that's just the way it's going to work. And so, again, I wonder if it might be better to have some kind of sensitivity approach where you have some different assumptions.
Yeah, I actually like that idea. We did trying to do the sensitivity analysis. For example, the odds ratio either go to the left direction, 0.5, or go to the right direction, 1.5. We did try to do that, so to see how much impact this study will be.
Did, what did you find when you did that, or do you?
Actually, so we are trying to think. We didn't do that yet, so that's our next step. So now we have the fixed number. So we say, let's say the odds ratio is 1 with no association either way. But we had a meeting today, so in our group to discuss the sensitivity analysis. We actually we agree with Roger's comments. So that's why already decided. So we will use a different odds ratio to do the estimate to say how much difference. I mean, if we use a different, like the imputation or assumptions, how much impact will be put in.
Well, great. We look forward to seeing those results. Thanks so much, Lee.
Thank you.
Yeah, thank you, Lee, very much. Up next, we will be hearing from Aditi Vernoniki. Aditi, do you want to start sharing your screen?
Sure. So I guess you can see my screen now.
Yes, we see the, yeah, now we see your slides. Wonderful.
Excellent. So thank you so much for the kind invitation, and I'm very excited to be here with all of you today. So this presentation is about dealing with retrieval bias for an evidence-informed individual patient data network meta-analysis. I have no conflicts of interest in relation to this presentation. However, this project was funded partly by the CHR Drug Safety and Effectiveness Network and the CHR Knowledge Synthesis Grant. So personalized medicine is required to optimize healthcare decision-making. And actually the use of individual patient data in meta-analysis is considered the gold standard approach to synthesize evidence across clinical studies. And when we say individual patient data, we mean the data from each individual patient who was enrolled within each of the studies that were eligible for a systematic review. So the use of individual patient data in the indirect comparisons and network meta-analysis has steeply increased since 2007. And this is mainly because we have several advantages when we use individual patient data. We can, for example, harmonize inclusion and exclusion criteria across the different studies. We can explore treatment by covariate interactions, potentially, or we can explore better heterogeneity and inconsistency within a network. So we have several advantages. So probably that's the reason that we, most of the authors have now started using individual patient data in network meta-analysis as well. However, the use of IPD in NMA usually includes non-sponsored and publicly sponsored studies. And so far, evidence suggests that sharing IPD may depend on study characteristics, such as the funding type, the size of the study, the risk of bias, or the treatment effect. And so far, it hasn't been explored whether there is a retrieval bias in network meta-analysis that use IPD from sponsored RCTs. So we wanted to explore what are the challenges and the barriers in these cases. Particularly, missing data can distort the medical literature, and it is one of the greatest threats in the meta-analysis. And using only a portion of studies within the meta-analysis or the network meta-analysis, only a portion of studies with individual patient data can certainly impact on the results, can impact on the decision-making as well. So we want to explore how feasible it is to obtain individual patient data from published RCTs. And this is when we decided to conduct a randomized control trial where we randomized the authors of studies of RCTs that were eligible for a systematic review. So we randomized the authors to two groups, the intervention and the control group, where in both groups we contacted the authors via email, mail, and phone. And in the intervention group, we also provided the authors with an upfront incentive of $100 Canadian, as well as with an acknowledgement and an invitation to collaborate with us in the project, in the final publication. So as a result, as expected, actually, the incentive didn't play an important role. But one third of the authors, irrespective of the group, did not respond to any of our attempts, actually. The 33% of the authors responded negatively. So they had lack of resources or time, they didn't have ownership of the data, or the data were old, so they couldn't really retrieve the data. And around the 35% of the authors responded positively to us. However, none of these authors shared their data with us. So I think this is a concern. And these are the two systematic reviews and network meta-analysis that we conducted. So one is about the Alzheimer's dementia, and the second one is about type 1 diabetes. In both systematic reviews, we wanted to personalize the medicine according to the patient's characteristics. And here you can see the two network plots from the two network meta-analysis. And in the network plots, you can see I have highlighted with different colors some of the edges. The black color shows that we had no individual patient data, whereas the green or the orange color shows that we had at least one study with individual patient data. And since we had no individual patient data shared from the authors, we had to identify these data through other ways. And this is when we decided to start contacting the sponsors and the data sharing platforms. So we contacted Vivli, Yoda, and CSDR, and we're very thankful to them for providing us with some of the data. So what we noticed is that newer studies with larger sample size and a smaller treatment effect were more likely to have IPD that was available. And in the two systematic reviews, what we started, for example, in particular for the Alzheimer's dementia, we started contacting 15 sponsors, whereas 6 sponsors really shared some of the data with us. And in the 6 sponsors, we requested 46 RCTs, and we received only 14 RCTs. Although we gave them ample of time, more than 1,000 days, then this is all we got. For type 1 diabetes, we contacted 2 sponsors, and 1 sponsor shared the data with us, and these were 12 studies. So in the Alzheimer's dementia systematic review, although we received 14 studies, we were able to include in the network meta-analysis 12 RCTs. And this is because we had some data with missing data that we weren't able to include in the network meta-analysis. For example, one of the study that we received included data only for the placebo arm, and we didn't have any data for the treatment arm. So this could not be included in the NMA. Then the second study that we received and we couldn't include in the NMA did not include any outcome data at all. So we only had some of the characteristics of the patients. Then another big challenge for the IPD that we received actually was the high dropout rate from the RCTs. And when we had a look at the publication, the original authors, many of them, if not all, used inappropriate methods. The good thing is that 2 of the studies that we received, although in the final publication didn't report the outcome that we were looking for, the data that we received included this outcome. So we were able to include more data in this network meta-analysis than what we would have included with the aggregated data. For type 1 diabetes, we were able to include all the RCTs that we received. So some challenges that we encountered during all this process is, first of all, the identification of the data set, the identification of the study, and particularly for the older studies, the studies that weren't published up until 2005, that didn't have an NCT number. Then another challenge was the data ownership, particularly for studies that were co-sponsored from multiple sponsors, and then we had issues with the ownership of the data. Then another challenge was while we were conducting the analysis and we were navigating the data, the sponsors switched platforms, and then we had to familiarize ourselves with the new platform and start the analysis from scratch sometimes. Then the software availability. Some of the sponsors did not include all the software that we required. And for example, for the R packages that we required when we were conducting the analysis, some of them were not available, and we weren't able to install these by ourselves. So since we didn't receive all the IPD for all the studies, and we had to conduct the analysis through the sponsor-specific platforms, then an one-stage analysis was not possible. So we also have a certain amount of time that we were provided with access to the data. And after that, we would be, there was a cost associated with this. But also a cost was associated with some of the additional information that we requested, so that we had to purchase an extra license. But also, finally, the available data were not in fully available, actually. Some of the studies, as I said, include only data for the placebo arm. Another study includes, didn't include any outcome data, or another study included coded dates, and we weren't able to see which is the first and the last date of follow-up. So how these findings will increase scientific knowledge? So well-conducted individual patient data network meta-analysis facilitate tailored decision-making. Although we were able to obtain data for studies that didn't report outcome data in the original publication, we found that there is some retrieval bias in our knowledge synthesis, and this can severely impact on the findings. So in particular, we received 15% of the eligible RCTs in the Alzheimer's dementia systematic review, whereas the 46% of RCTs was available for individual patient data for the type 1 diabetes. So far what we can say is that IPD sharing is not yet well established, and in particular in the two fields of Alzheimer's dementia and type 1 diabetes, and we need more efforts to achieve this goal. We need more efforts to share the data, the individual patient data, to allow for secondary analysis. Thank you. And I'm happy to answer any questions.
Okay, thank you so much. We have one question from Lee. Can you share tips for improving the success in obtaining IPD data? And go ahead, Lee, if you want to expand on that question. Lee, you're on mute.
I'm sorry. So I'm very interested about how do you obtain the IPD data, because I know it's very difficult to get the IPD data either from a sponsor or from authors. Do you have any tips, I mean, to improve the success?
That's a really great question. So this is our, what we tried is first to contact the authors, and particularly, I believe that we were unsuccessful in retrieving the individual patient data from the authors because the data were mainly sponsored by pharmaceutical companies. So actually the authors didn't have ownership of the data, even if they analyzed this. Right, so this is something that we need to pay attention when we actually want to conduct a systematic review. We need to see if the studies that we include in the systematic review are pharmaceutically sponsored. So then if they are, then we can, of course, contact the databases. But we need to have in mind that we need a lot of time. So as you can imagine, this took us around 4 years, and because we had to go back and forth with the sponsors, the authors, explaining to us, because we had so many questions about the data. So this required a lot of time, and it's not a regular systematic review with an aggregated data that you have in your computer and you can do the analysis as much as and at your time. So it's a really different process. So yeah, time and money, I think this is my tip. Yeah.
Thank you.
I have a question.
Go ahead.
Hey. Hi, Argi. This is Ahmed.
Hi.
Nice, very good presentation. It's nice to see you again. So questions. So I just wonder, like, what's the difference between, like, if we do two reviews, one with the IPD and one with aggregate data, are the results gonna be very different? Because I'm just thinking, is it like really worth it, all this work, or just easier to go with aggregate data? And yeah, what's the benefit of it? Like, major benefit of that?
Right. So this is again another Great question. So it depends on what your research question is. So if you want to, I guess, if you want to tailor the results of the systematic review to the patient characteristics and, for example, sex or language characteristics, I don't know, so things that are patient characteristics that we cannot really have this information on the aggregate level, because usually publications report on this on average, so irrespective of the different characteristics that we may be interested in. So things like that, I think, are key differences between the individual patient data and the aggregated data systematic reviews. But also it's sometimes, for example, when we conduct a network meta-analysis and we have inconsistencies that we cannot, for example, find why these inconsistencies here. So then things like this the use of individual patient data may help us respond to such questions or explore heterogeneity better. And as I said, treatment by covariate interactions, I think, are more easily to be located with individual patient data. But if you don't explore patient characteristics, for example, and you are interested overall whether the treatment works in general, so I think an aggregated data sharing systematic review would be the best.
Can I ask one more question?
Go ahead, we have 1 minute left.
Yeah, okay, thank you. So, because as you said, we cannot get some of the IPD data from some studies, right? So, because you are doing the lateral meta-analysis, you will lose some nodes, correct? In general, if you don't have the IPD data.
Yep.
So you have to incorporate your IPD data with the aggregator for the.
Yes. Exactly. So you have to conduct statistical analysis that you combine both aggregated data. Oh, is it okay? Sorry. I thought it was my internet connection, so that's why I stopped. Okay, so you have to conduct statistical analysis that combine individual patient data and aggregated data, because if you ignore one great part of the studies, then your results will be biased. So we have to make sure that we use the optimal analysis. Yeah.
A further question about that, because we know the IP data is, you have a benefit to do more, like explore the heterogeneity, right? You can use more complicated data to explore heterogeneity, but you lose that part for those aggregate set.
Exactly. So,
so how can you incorporate that for into your subgroup analysis or something else?
So, we are at time, and if this sounds like a conversation, so I would encourage you to chat with Areti and continue the conversation.
Thank you
so
much.
Glad to see the engagement. Thank you all for your presentations.
Thank you.
Yeah, that was wonderful, everyone. Thank you. I echo Christine's thanks. So right now we have a little bit of a lunch, 15-minute break. Brooke, Jennifer, and Michelle at about 1:15, so about 45 past the hour, I will be back here to do a little mic check for you three. So thank you, everyone, and we will be back in a few minutes.
Celia, can you hear me?
I can hear you just fine. Yep.
Okay. Thank you.
Brooke, Jennifer, and Michelle, would you just mind just piping up and just saying a quick hello so we can make sure that your microphone is working?
Hello, it's Michelle.
Hi, it's Brooke.
And Jen here.
Wonderful, ladies. Thank you so much. We will get started in just another 3 minutes. We will get started.
How are you? Good.
Hi, folks. All right, welcome back. I think we can begin our transition to getting started. Thank you to all of our previous speakers, and we're very excited for our next few speakers. As a gentle reminder, please mute yourself if you are not talking, and please send in any questions that you may have for our upcoming speakers over chat. So our next session is going to be on improving the use of systematic reviews, and we will be hearing from Brooke Levis. Brooke, feel free to go ahead and start sharing your screen. Wonderful. Feel free to go ahead and get started.
So thanks for having me present today. So this presentation is going to focus on the development of a knowledge translation tool based on the results of a meta-analysis. So once we have the results from meta-analysis, now translating it for clinical use. I have no conflicts of interest. So depression is common in medical settings, and it's associated with poor prognosis. And because of this, depression screening is something that is often recommended. So the goal of screening is to act as a sort of net. We want to identify patients with depression who have otherwise been unrecognized. So in this picture over here, let's say the pink individuals are depressed and the gray are not. We want our screening program to identify as many pink ones as possible without identifying too many of the gray ones. And this is done using depression screening questionnaire. So here you can see the Patient Health Questionnaire 9, or the PHQ-9 for short. And this is the most commonly used depression screening tool in clinical practice. So it's a multiple choice questionnaire. It has 9 items. Each of these items map onto one of the 9 symptoms for major depression from the DSM manual. And each, a respondent, so a patient who's completing screening will answer each of the questions based on how they've been feeling. And at the end, they will calculate a total score. And then depending on the score from this tool, there'll be a different follow-up. So if the score is low, that's a negative screen and there's no further assessment. But if the score is high, then there'll be a further assessment with the clinician to establish a diagnosis, so major depression or no depression, and if appropriate, treatment can be offered. So that's the general paradigm of depression screening. And when we want to know how good these tools are at identifying depression, so with the PHQ-9, can we capture most people with depression? We evaluate what's called the diagnostic test accuracy of the tool. And to do this, we do studies where every patient in the study is administered the screening tool. So everyone fills in this Patient Health Questionnaire 9 questionnaire, and everyone receives a diagnostic assessment. So an interview with a clinician who can diagnose depression or no depression. So in the end, everyone in the study will be positive or negative screen from the PHQ-9 and a positive or negative case from the clinical interview. And with this distribution, we can calculate accuracy parameters such as sensitivity, specificity, and predictive values. And one particular nuance with depression screening compared to some other types of screening is that our questionnaire gives us a continuous score. So depending on how you answer the questions, your score can be anywhere from 0 to 27. And you have to define at what point you're going to call us, like what is a high score that's going to be a positive screen and what's a low score that's a negative screen. So you might want to use a 10. So 10 or higher is a positive screen and 9 and below is a negative screen. Or you might decide you want to use a score of 15 or 20 to identify a positive screen, or a really low score might be 5. And depending on where you draw the line here, so how you define your positive versus negative screen, you're going to get a different distribution of patients in this 2 times 2 table. Therefore, depending on which cutoff you use, you're going to get different estimates of diagnostic accuracy. So in order to rigorously evaluate what the diagnostic accuracy of the PHQ-9 is, I conducted an individual participant data meta-analysis, or IPDMA, which you just heard from in the previous presentations a little bit. And the goal here was, so we collected a bunch of studies that had assessed the accuracy of the PHQ-9, put all those data sets together into one large data set, and then we evaluated the accuracy according to different thresholds for positive screen. So here were the main results. So this is what's known as an ROC plot, and it basically maps the pairs of sensitivity and specificity for different cutoff thresholds. So here's a score of 5, and then all the way up to using cutoff threshold of 15 or positive. So again, this is how we're defining our positive screen. And in summary, we found in this study that a cutoff score of 10 or higher maximized the combination of sensitivity and specificity. Also, sometimes we say this is like the one closest to the top left corner. And at a cutoff of 10, there was 88 sensitivity and 85% specificity. So that's what we found in the meta-analysis. But so what? What does this even mean? So if you're a clinician who's considering screening for major depression, what cutoff should you use? Should you use a 10? Well, this 10 was determined by saying that sensitivity and specificity were equally important. What if you have a different priority? Maybe you want to really focus on sensitivity or really focus on specificity. Also, in terms of understanding these numbers, what does 88% sensitivity even mean? And there's a common misconception that 88% sensitivity means that if you screen positive, there's an 88% chance that you truly have depression. But that's incorrect, because if you think about those 2 times 2 tables that I showed before, it's actually kind of the opposite. So sensitivity is telling you the likelihood of a screen given a diagnosis, but we really want to know the likelihood of diagnosis given the screen, and this involves a transformation. So in order to try and answer these questions, I worked on developing a knowledge translation web tool. So the goal of the web tool is to create a user-friendly, so for clinicians to use, easily usable website where, based on the sensitivity and specificity results from the IPDMA, a clinician can have a better understanding of what would happen in their clinical practice. So for a given depression prevalence, so whatever prevalence of depression they think they have in their practice or in their certain patient group, and picking a certain PHQ-9 cutoff score, how many patients on average would screen positive versus negative, and how many in each group would be correctly versus incorrectly identified. So we want to look at how many false positives and false negatives there are, because we want to really minimize those. And because this website is intended for clinicians who are considering screening, I consulted with several family physicians during development to make sure that the tool was easy to use, that it was clear, comprehensive, and that it really addressed the needs of clinicians who are considering to screen for depression in their practice. So I'm going to just show you some snapshots now, and then if I have time, I'm going to show you the actual website at the end. So basically, so the tool can be found at depressionscreening100.com/PHQ. And the first thing you need to do is enter in a prevalence of depression that you think you have in your practice. So any prevalence between 1% and 100%. So for illustration purposes, I put in, let's say, prevalence of 10%. And then you have to pick a cutoff threshold. So how are you going to define a positive versus negative screen in your practice? And so the default is 10, but anyone who's looking at this website can change this by sliding this bar up or down to pick a different cutoff. And again, I'll show you later what happens when you change the cutoff around. But just using these two values, so prevalence of 10%, cutoff of 10, once you hit calculate, this 10 times 10 person diagram is self-populated. So that there's coding done behind the scenes to make this present the results based on the IPD meta-analysis. So with these parameters, out of every 100 patients that the clinician would screen in practice, 22 patients, so the blue and red, would screen positive, whereas 78, so these gray and black, would screen negative. And then when you look within each group, so among the 22 positive screens, 9 of them would be truly depressed, whereas the other 13 would not be depressed. So these are the false positives. And on the other hand, out of the 78 negative screens, the gray individuals would truly be not depressed, and the black individual would truly be depressed. This is a missed case. And again, depending on which cutoff you use, you're going to have a different distribution of patients in this diagram. So a clinician who's deciding whether which cutoff they want to use to screen, they can decide for themselves, okay, how many extra false positives am I willing to have to minimize the number of false negatives, or vice versa. So you can play around with it and see what would happen, again, on average. So just to summarize before I show you the actual website, so this web tool improves clinician understanding of results from the IPD meta-analysis by translating the results of sensitivity and specificity that we found in the meta-analysis into numbers that are more readily understood, so these natural frequencies that are easily to interpret. And we also provide guidance on how to use it on the website. So I'll next show you the website. So here's the website, and again, you can take a look at it later because it is freely available if we're out of time. But so it just starts off with a little introduction of what this tool does. Then it tells you to enter in your prevalence, and there are some tips and tricks on how to pick your starting point, some examples that you can click through to find. Then you enter your prevalence, let's say 10%, cutoff of 10, you hit calculate. It's not working. Brush. There we go. So here's with the cutoff score of 10 or higher, but let's see, just to show you an example, if you make that threshold for defining a positive screen higher at 14, you're gonna see that there's fewer false positives, but you are gonna miss out on 4 cases. So you have a different, again, this different distribution. And let's say you make the cutoff really low and you hit calculate. So with a really low cutoff, well, you're not going to miss any true cases of depression, but you're going to have a lot of false positives. So again, this is an interactive website, and it does all the work for you. You just have to enter in the prevalence and then pick your cutoff, and you can see these this diagram self-populate. And at the end, there's some frequently asked questions and the references for the paper and other resources for clinical use.
Thank you, Brooke. And this session is being moderated by Yurato. Yurato, I think you're on mute.
Oh, sorry. Oh, thank you. Yes, thank you. Thanks, Celia. Thank you so much, Brooke. That was very interesting and exciting. Someone is asking in the chat for you to share the link if it's already publicly available. Okay, so if you could put that in chat at some point later, that would be great. If there are any other questions for Brooke, please add them to the chat now. In the interim, I guess I'd like to, well, Roger has a question, but let me, I have jotted something really quick down. So how often do you think a clinician would have to assess, run this analysis to get sort of an accurate assessment of the depression in their patient pool?
So this, I would say that they could just do it. I mean, it's just based off of, like, you pick what you think is the truth in your population. So what do you think the prevalence of depression is? And that's probably a pretty stable prevalence on average. So that value is not going to change. And then there's picking the cutoff. So I think they could just play around with this once and decide which cutoff, like which balance of how many false positives versus false negatives they're willing to have. So if they really want to prioritize, you know, not missing any cases, that they can see, okay, well, I'm going to have so many more false positives. And then they have to think, well, okay, when you have, like, you don't know who are the true and false positives until you do the further assessment. And that takes a lot of resources, right? So depending on how many resources your clinic has, you might be willing to refer more people for the further assessment or less people for the further assessment. So I think it is very dependent on individual situations, which is one of the reasons why we didn't want to just recommend using cutoff 10 for everybody. We really want clinicians to have this ability to decide for themselves. And I think it's a very personal, I'm not a clinician, but even in speaking with clinicians, it's a very personal choice. I know some physicians who work up north in remote areas, they really don't want to miss any. It's really important for them to not miss cases. So they really prioritize sensitivity, no missed cases. But someone busy in the city, they might not have the exact same perspective. So I think, yeah, there's no hard answer here, unfortunately.
And then at some point, I mean, this doesn't preclude use of the PHQ-9 or other questionnaires to have self-reported outcomes, correct? It's to be used in tandem with the questionnaire?
So this is like a before administering, so this is just all based on the PHQ. We're doing similar projects with other questionnaires. This tool is just for the PHQ-9. So if you are considering using the PHQ-9 in your practice, you need to know before you administer the questionnaire out what score am I going to call a positive screen, a negative screen, right? Because there's a questionnaire, you can have scores from 0 to 27, and that this tool is to make that decision of what you're going to use to define your positive and negative screens.
Okay,
so
great.
This is to decide which cutoff to use in the screening tool, and then the next step after the screening is to refer for the clinical diagnosis.
Perfect. Thanks for clarifying that. We have a question asking if you have any metrics on use of the website to date.
We did install Google Analytics, so I can get back to you on that. I have to speak to the computer programmer who worked on the back end of this, but I can send that to that person later.
Sure.
Yeah, just have them contact me.
Perfect. And I think you already answered this, but we have someone asking how providers are supposed to assess prevalence per practice, but I think you had already answered that previously. And then a follow-up question, how is your meta-analysis different from published meta-analyses of PHQ-9?
So this is completely based on our published meta-analysis. So we did we did an individual patient data analysis. We took all the data from all around the world. We estimated sensitivity and specificity. So that's what that BMJ paper that I showed earlier looked at. And I can send the link if you want to look at that paper. And then just using those estimates of sensitivity and specificity by plugging in the prevalence values, then that's how you get to this 10 times 10 person diagram. So this is just a reconfiguration of the same information, but it just makes it more easy to understand because sensitivity and specificity are very, methodsy concepts, whereas the natural frequencies in the 10 by 10 person diagram are easier to understand. So it's the same information, just presented in another way.
Great, thank you. Roger, do you have a question? If not, we're gonna move on to our next speaker. I think we're okay. Thank you so much, Brooke. So next, Celia, would you like to introduce the next speaker?
Yes, up next, we will be hearing from Jennifer Watt. Jennifer, feel free to start sharing your slides when you're ready. Down at the bottom of your screen,
Oh,
there should be
yes.
a full screen option.
Sorry, I just realized I have far too many windows open. I can't find, 1 second. I just need to close a couple of things.
Oh, no problem.
I was like, why can't I see it? But there's just too many things open. Okay, let's try now. There it is. So good afternoon, everyone. My name is Dr. Jennifer Watt. I am an assistant professor in the Department of Medicine at the University of Toronto, and I'm also a geriatrician, which I know the training for geriatricians differs slightly across countries. And so I would just explain that I completed medical school and 3 years of internal medicine training, followed by 2 years of subspecialty training in geriatrics. And so the topic for my presentation today is using a distribution-based approach and systematic review methods to derive minimum clinically important differences. So the problem and potential solution that we're going to talk about today arose sort of from two complementary places, if you will. So one, in me sort of wearing my two hats as a clinician and as a researcher, I very frequently have to provide information to my colleagues as well as to patients and caregivers. Does this study change my practice, or at least does it inform my practice? And so to know that, it's important to know, is a result statistically significant, but more so, is it clinically meaningful? And so, how does this information apply to the work that I do? And then secondly, what happened was I was doing my PhD work. So part of my PhD work was a systematic review and network meta-analysis of interventions. And so what happened is I submitted one of my papers for publication, and the reviewer comments come back and they say, well, this is great, but you presented your outcomes as standardized mean differences, which was because there were more than 20 different scales used to report the outcome that I was interested in. And so the question was, what does this really mean? And I was like, well, really good question. And so, here we are. And so how could I possibly look at a way of, figuring this out? And unfortunately, the scales in this setting, the minimum clinically important differences were not known. And so what was I going to do? And so that's how I came to what we're going to talk about today. So a minimum clinically important difference for a scale, many of you probably know this, but it's the threshold above which we would perceive a difference in an outcome. So not just statistical significance, but if I'm assessing a patient in clinic and I'm using a scale, what change on that scale would be meaningful to me, and that I would perceive a difference in my patients. And there are two sort of groups of approaches classically used, one being an anchor-based approach and the other being a distribution-based approach to deriving a minimum clinically important difference. So an anchor-based approach is when you compare a change in a scale-based outcome measure with that of either a patient-reported outcome, which could be like a global rating of change, or other external criterion like expert opinion. The problem with that being, of course, is that there's bias in that as clinicians, we're more likely to be influenced by those like really outlying cases or more recent cases, and certainly by the patients that we see in our practice. So what I might report as being clinically important might be very different from my colleagues in Vancouver. The other approach is a distribution-based approach, and so in this type of approach, you compare the difference in a scale-based outcome measure to a pre-specified threshold value of its uncertainty. And so, to sort of think about this, the Cohen effect sizes. So 0.2 standard deviations is considered a small difference, 0.5 is a moderate difference, and then 0.8 being a large difference. And certainly, literature suggests that a difference or between 0.4 and 0.5 standard deviations is where most clinically important differences will fall. And so having said all this, can we improve estimation of minimum clinically important differences with knowledge synthesis methods and enhance interpretability of meta-analysis results? And so our objectives are to describe an empiric example where we applied a distribution-based approach using data that we had from a systematic review to derive a minimum clinically important difference for our outcomes of interest. And then we want to compare our derived MCID values to published MCID values. So to avoid confusion, because I realized this might confuse people a little bit, is the case from my PhD, there weren't published MCID values, so I'm not talking about that. But then when I went and talked with my supervisors and committee, we realized that we had other data where the minimum clinically important difference values were known. And so then we said, okay, as like a methods project, let's look at an empiric example to see how well this alternative method that you're proposing can work compared to other established values. And so, as I was saying, we used a data set from a systematic review and network meta-analysis of the comparative effectiveness and safety of cognitive enhancers. And these 4 treatments I want you to keep in mind because we're going to talk about them again in a few slides. So donepezil, galantamine, rivastigmine, and memantine, and these are used for treating Alzheimer's disease. And in our data set that we used to arrive at our MCID values, we included all the studies that were parallel randomized trials that reported either a baseline mean or a mean change value for the MMSE, which is the mini mental status exam, or the 11-item version of the AHRQ, which is another cognitive test. The studies had to report a standard deviation for the baseline mean or mean change value, and they had to report the number of participants per study arm. And where the standard deviation wasn't reported, but say a standard error or confidence intervals were reported, we used accepted imputation methods to approximate standard deviations. And that's the reference for the systematic review that provided this data set. And so then next, what did we do? So we used equation for pooling standard deviations that's based on the publication by Furukawa et al. That is actually meant for imputing missing standard deviation values in meta-analyses. And so the NI is the number of participants per trial arm, SDI is the standard deviation value per trial arm, and then what you do, so once you get your pooled standard deviation, you can multiply that by what you think is an appropriate threshold. So for example, as I said, it looks like in a lot of cases, minimum clinically important differences between 0.4 and 0.5 standard deviations tend to be a range of sort of plausible MCID values. And so you could consider using those values. And so what were our results? So here, as I talked about before, I'll discuss results for the MMSE and the AHRQ, so 2 very commonly used studies or scales in this body of literature. You can see for all 4 of the analysis groups, there are more than 10,000 patients included. And so when we looked, and so I report separately where we estimated the MCIDs using baseline standard deviations and then mean change standard deviations. We show here the range of standard deviation values. So you can see there's quite a range, which is part of the reason why I wanted to look at using systematic review methods as well, because we know, in the Cochrane handbook, for example, they suggest, use a, representative observational study, but particularly in observational studies of interventions, there's lots of potential bias, important, selection bias, indication bias, for example, and there's quite a range of standard deviation values in those non-randomized studies there. And so you have to be really careful which ones you would pick or use several different ones and show a range of plausible values. And so that's why we kind of lean towards trying this. But what I mean to say for this slide is that you will see, at a value of 0.4 standard deviations for the baseline, using baseline measures, you get 1.6, and then at 0.5, you get up to 2. And then for the mean change, it's slightly smaller. Clinically, when we score this scale, you don't get partial points. You lose 1 point or 2 points. So these results are very much in keeping, actually, with reported minimum clinically important differences derived based on distribution and anchor-based approaches. 1 to 2 is a very commonly accepted range. So that was really reassuring. When we looked at the AHRQ for the baseline standard deviations, we see at 0.4, we get a value of 4, and at 0.5, we get a value of 5. The results are, the range or the MCID values are a little bit smaller when we use the mean change values. Clinically, again, or in the published literature, when we look at using anchor and distribution-based approaches, this value of 4 to 5 is typically in the range of what we would expect. So it looks like using the baseline standard deviations, you get a little bit more conservative estimate and perhaps a little bit more in keeping with other values that you might derive in a primary study. So what about, because in the last slide, sorry if I didn't make this clear, so this was a network meta-analysis. So we actually used all of the studies. So whether or not they were comparing, say, memantine to placebo or donepezil to placebo, everyone was in here. But we know that, you know, sometimes we're doing a systematic review and pairwise meta-analysis, or we're only looking at, you know, 2 treatment groups. So how did it work in this case? And so here I present to you, you know, the individual treatment groups so that you can take a look at this. And you see it worked pretty well. Very similar results across the board. When we look at using the baseline and mean change values, this is for the MMSE specifically. And then here, when we look at the AHRQ, there's just one thing I'd like to point out, because I think this might be important, is that there could be a minimum number of studies that you need to get representative values. In that, if you look at memantine and you look at the mean change, there's only 3 studies, and the MCIDs at 0.4 and 0.5 are a little bit different than were the other values. And it could be because it's small, you know, only 3 studies. There was actually quite an influential study in there as well. And so it may be that you need 4 or 5 studies to really get a more accurate picture of what the uncertainty distribution is. And so important limitations, you know, we don't know if this approach is generalizable to all situations in which a scale is used. Here it looked to, you know, line up pretty well with the published literature, which is reassuring. And what may be important, and we didn't look at this here, but we are looking at this, is, you know, what's the effect of modifiers, effect modifiers. So for example, would you expect the minimum clinically important difference to be the same, you know, in men and women, or where the distribution by sex or gender is different? And so we don't know that. And so in conclusion, I would say, you know, this might be an approach that we can use certainly when there aren't known minimum clinically important differences, because I think, you know, to be very pragmatic about this as a clinician, I think it's really important to be able to explain my findings to my colleagues and patients and caregivers. And then, as I noted, it might be a little bit more conservative to use the baseline as opposed to mean change standard deviations. And then in the future, you know, we've talked about some limitations that, you know, we're working on and hoping to explore in the future. Like everyone, you know, the COVID-19 pandemic has, you know, set me back a little bit in this work, but certainly this publication is written up and is imminently going to be submitted. So that's the citation here for the abstract. And I'd like to thank my colleagues, Drs. Veroniki, Trico, and Strauss. But I will be, you know, hopefully this publication won't be out before long, but if you need more details, that's my email address and my Twitter handle. And
thank you so much, Jennifer. That was excellent. It was dense. It was complex, and thank you so much for working that out for us. I think we have a minute left in your session. I don't see any questions in chat, but I have a quick question. Actually, we are getting a couple of questions. Do you plan on applying this method or testing its validity in conditions outside of geriatrics to see if it is still applicable?
So I'd really like to do that. So I've used this so the one paper from my thesis, and then the data set that, you know, we had from previous work, and I've actually just used it. So I'm working on revisions for a paper. I've used it there. But yeah, because I'm a geriatrician very early in my career, I haven't had the opportunity to use it in other data sets. But I think, you know, that will be really important, is it across other clinical scenarios and potential effect modifiers. How robust is this?
Thank you. I think I'm going to consolidate a couple of questions, and I think people mostly want to know how this compares to anchor-based MCID work.
So that's what is really great. So I can never memorize all of these, but I've got them. So I've got the manuscript up on another screen because I was like, this has all the information that people will want to know. And what was actually really good is in terms of, did I misunderstand? Sorry, repeat the question. Were you talking about the AHRQ or you were, sorry, repeat the question.
The question is, have you compared your MCID from the systematic review with anchor-based MCID?
Yes. Oh, sorry. So that's what,
yeah.
Okay, thank you very much for repeating that. So yes, I have across the MMSE and AHRQ, both tools. And what's really good is that it looks to be quite comparable. But again, that the baseline standard the approach with the baseline standard deviation seems to work better, or at least be a little bit more conservative than the mean change. There is one exception to that with the MMSE, and it's just interesting actually because I didn't even know that this paper about this anchor-based approach with the MMSE existed, and I looked at it, and it had that the minimum clinically important difference was almost 4. And
Jennifer, I'm sorry to interrupt. I think we're going way over time.
Okay.
It would be great if you can, those in the chat who have specific questions for Jennifer, if you can get in touch with her privately through chat or send her an email, that would be great. Sorry, Jennifer. So let's move on to our next speaker, Michelle.
Yes, and Michelle, we will, you are welcome to have an extra 2 minutes at the end of your talk. Thank you for giving us that extra time.
So I'm really excited to be here to talk about our progress towards moving towards a reporting guideline for overviews of reviews. I just wanted to start out by acknowledging the author team who has been involved in this project, because I really would say that it's been a true team effort to get Prior to where it is today. So we have no conflicts of interest. So I think most of the audience here is probably familiar with overviews of reviews, but I wanted to provide a little bit of background for anyone who is not. So overviews of reviews, I would say, is a study method that uses systematic methodology to search for and synthesize data from multiple systematic reviews on a similar topic with the purpose of mapping, synthesizing, and or exploring discrepancies in the evidence. So as you can see from this definition, there's many similarities to systematic reviews. However, the unit of analysis will differ. So in the systematic review, your unit of analysis will be the primary study, whereas in the overview of reviews, your unit of analysis is actually the systematic review itself. So while there are quite a few similarities, having this differing unit of analysis does make for some unique challenges with the overview of reviews. And one of the main challenges is just the increased complexity in dealing with 2 layers of information. So with overviews of reviews, we have to deal with, first of all, this included systematic reviews, and then there included primary studies, from which we're becoming increasingly distant at the overview of reviews level. And secondly, there's many aspects of methodology for the overviews of reviews for which we still don't have consensus on the best methods. And we're still lacking an evidence and consensus-based reporting guideline for overviews of reviews. So with Prior, we are trying to address some of these concerns or challenges. So our plans for Prior were to develop an evidence and agreement-based reporting guideline for overviews of reviews of healthcare interventions using explicit, systematic, and transparent methods based on guidance of the Equator Network. So this has been a 4-phase process, which I'll outline briefly on this slide, but then I'll go into a little bit more depth on in the coming minutes. So first, we launched the project, where we identified and invited experts who will be involved in the day-to-day operations. We then updated existing literature reviews to help to inform our prospective item list. Next, we conducted a 3-phase Delphi process to aim to get agreement on the preliminary items for the item list. And at this point, we're at the stage of developing the final guidance document. So the first step was launching the project, and at this time we established a core team who would be responsible for the day-to-day operations of the project, and those were the co-authors that were listed on the first slide. And then we identified a 3-member expert advisory board who are experts in methodology, the methodology of overviews of reviews, as well as guideline development, and have experience on editorial boards. So they'll provide key expertise at all phases of the project. They are involved in the Delphi exercises and help to facilitate the in-person meeting. And they'll also assist in producing the guideline at the end. We registered our intent to develop prior on the Equator Network in 2017. And then we went ahead to plan the project and preliminary timelines, which we published in an a priori protocol in 2019. And finally, we obtained ethics approval to undertake the project. Our next step was to update some existing literature reviews that were conducted by our team. So the first was a methodological review of the reporting of existing published overviews published between 2012 and 2016. And this was led by Dr. David Pieper in Germany and his team. And what we found was that there is quite a bit of heterogeneity in the way that existing overviews are reported, not surprisingly. And although we don't have a reporting guideline yet, we could say that probably many of these overviews are poorly reported. Next, we updated a scope and review of methodological guidance for overviews of reviews. And to date, we note that there are 77 different guidance documents available to authors of overviews, but there remain several areas of conflicting or lacking guidance. So for example, when to include primary studies, how to manage primary study overlap, and how to rate the certainty in the evidence. And we used the information from these reviews to develop what I'd say is a quite exhaustive list of preliminary items for the guideline. So when developing the item list, we decided that we were going to develop a standalone guideline rather than a Prisma extension. And our reasoning here was this would allow us to focus on the particular challenges related to overviews and allow for future guideline extensions, for example, prior for abstracts or prior for diagnostic overviews. So we included several items in the guideline that are unique to overviews of reviews, and I've provided a few examples here. For example, within the rationale, we asked that authors describe why the overview of reviews format would be the most appropriate methodology for answering the research question. In terms of eligibility criteria, we ask authors to specify their pre-established definition of a systematic review. And at the data extraction phase, we ask that authors state any methods to deal with overlapping data from primary studies. Our next step was to undertake the modified Delphi, and the Delphi is indicated here as a group facilitation technique that aims to obtain consensus from a group of experts. So our first step was to identify a purposeful sample of 100 international participants with a diverse expertise in conducting, reviewing, and disseminating overviews of reviews. These participants were invited to the first 2 stages of our Delphi process, which happened online, where we provided our preliminary item list and some evidence to go with these items. And then participants voted on whether they thought that this was an important item to include in the list or whether it could be excluded on a 5-point scale. And we had originally decided that agreement would be defined as at least 70%. And then after the first round, we analyzed the data and provided it back to participants, at which time they were able to reconsider their original decisions and try to come to consensus on a few more of the items. And finally, just this past week, we selected a subset of 10 expert participants to partake in an in-person meeting, which occurred online, where we tried to reach consensus on the final items. So just a little bit of background on our progress here. In round 1, we ended up having 53 participants. We achieved agreement for inclusion of 48 of the original 52 items that were suggested, and we achieved a lot of qualitative feedback. And we took this feedback into account and reworded one of the items that did not meet inclusion or exclusion, and added 5 new items that were suggested by participants. And then in round 2, so we had 9 items that were in that survey, but we did not reach agreement on inclusion or exclusion of any of these 9 items. So they were more tricky items for people to decide on. And then finally, we had our in-person meetings, as I said, this week, and we were able to, in these meetings, come to agreement, at least on the inclusion or exclusion of the concept of these items, although they will probably undergo more rewording in the future. So we've now made it to the last stage, which is development of the guidance statement. So this will involve refining the item list based on participant comments with the aim of producing clear, concise, and unambiguous wording for each item. And this may also involve condensing or reorganizing the items to make it to a manageable length. For example, we would maybe aim for 20 items with sub-items. We will then pilot test the checklist with a group of potential users and potentially on existing overviews. And the feedback from this will help us to finalize the final checklist. And in the end, we will have a writing group consisting of the core team, the expert advisory board, and the expert panelists from the in-person meeting to help us to draft the final manuscript and the explanation and elaboration document. And our final phase will be dissemination. And there's many ways in which we can disseminate. We're hoping to disseminate the guideline widely, for example, in obviously a peer-reviewed journal, but also many other methods. And if you have any innovative ways in which you think that this could be disseminated, I'd be happy to hear about your ideas in the chat box or in the question period. And also, I think an important piece here will be to evaluate the impact of the guideline as well over time on the reporting of overviews. So that's all I had for today. I want to say thanks for listening and also look forward to prior, hopefully by the end of 2021.
Thank you so much, Michelle. That was excellent. And if I heard correctly, slide 3 just was conducted this week. So we're in the midst of the study. So we feel privileged to have this information during the study period. I had one question before we get any others in chat. So your work entails direct input or engagement from 100 clinical experts, or at least 100 clinical experts. Do you have a built-in mechanism to adjust for or account for any potential conflicts of interest?
So yeah, we had identified about 100 experts that could possibly be involved in the reporting guideline Delphi, and then we had 53 who participated. We did not ask them about their conflicts of interest, but I suppose that at the manuscript writing stage, this would definitely become something very important to think about. So thanks for bringing that up. It's a very interesting point that I think we hadn't like extensively thought about, but I think, yeah, we're just interested in getting the feedback of people with various experience with overviews and try to get a broad range of expertise. But yeah, I think that's something important to talk about. Thanks.
We have a question from Dr. Negum in the chat. Are there any guidance, or is there any guidance on statistical reporting of overviews or reviews? Do you have other examples you could share?
So I guess in our scoping review of for overviews of reviews, we did not come up with specific statistical guidance for overviews of reviews. I know there is guidance saying that network meta-analyses, for example, are often not appropriate in overviews of reviews just because we have less familiarity with the primary studies that would be using in this. And I know in overviews of reviews, often the statistical methods that we would use are quite similar to systematic reviews. So perhaps the guidance would be quite similar, but I've not seen, at least in our overview or scoping review, there was not much related specifically to statistical techniques.
Great, thank you so much, Michelle. We look forward to the publication of your study next year. And I think that wraps up this segment, Celia.
Yes, wonderful. All right, so now we have just a little bit of a break, another 5-minute break, and we would like to do a quick, Lisa Hartling just let us know that the updated chapter on overviews in the Cochrane handbook was released in March of 2020, and it covers approaches to analysis. Thank you for that comment, Lisa. Yes, and so as I mentioned, we have a 5-minute break now, and if Marcy, Candice, and Eitan could just pipe up and let us know that their mics are working, we would appreciate it.
Yes, so this is Celia. This is Zaitan.
Hear you loud and clear. Wonderful.
Hello, Marcy's here.
Great. We can hear you loud and clear. And Candace?
Candace is here as well. Hi.
Wonderful, everyone. We will get started with our content at around 2:40 Eastern. Thank you. All right, everyone, welcome back. I think we are ready to go ahead and reconvene. So up next, our next session is going to be on improving the efficiency of systematic reviews. and it will be moderated by Adrian Stevens. And up first, we are hearing from Marcy Hager. Marcy, you can go ahead and share your screen now.
Can you see my screen? Okay.
Yes, we can.
Thank you. Sorry, everybody, I'm fighting with PowerPoint right now. There we go. Hello, everybody. I'm Marcy Hager, and I'm the director of the Evidence-Based Practice Program at Oregon Health and Science University. So I'm going to tell you a little bit about our process of doing rapid reviews within our health system. I have no financial relationships to disclose. So I'm going to give us some feedback, some background on why we do this at a health system level. So as some of you might be very aware, there is a 17-year evidence to practice gap. I like to use the opioid prescribing guideline as an example. In the late 90s, early 2000s, there was data that mortality was increasing from opioid overdose. And then research priorities were started, research synthesis happened. The CDC guideline in the US was released in 2016. And then from there, health systems started to make changes based on the guidance. So the point of our program is really to accelerate this process to reduce the 17-year evidence to practice gap by helping to facilitate the acceleration of guideline recommendations into healthcare delivery, but also to be able to use data that is emerging to help make recommendations and considerations before there is even systematic reviews that are available or guidelines that are available. So this is an overview of our process. We definitely do not recreate the wheel. We use national guidelines and primary research studies when we are appraising our literature using the grade methodology. And we then adapt with local data, patient values and preferences, and clinical expertise. We adapt by making recommendations that then become our health system guideline, and then we apply them. For this, I like to use the example of colorectal cancer screening. We've been working on a guideline for a number of years here at OHSU. There are a number of national guidelines that can be conflicting with, in terms of the age that is changing at the moment when we should start to screen average risk patients. But also some guidelines recommend that any screening tool is useful, but as a health system, that's not very helpful because we have to develop programs and systems to ensure that we can do that, to follow up with our patients, to ensure that the tests that we're using are as efficacious as a colonoscopy. So for OHSU, we went through the data and we decided to focus our tier 1 screening tools as colonoscopies and FIT tests, which FIT tests are at-home colorectal cancer screening tests. So we've been building programs, we've been working on integrating into EHRs, but also ensuring that the lab is involved so that patients can be screened annually and can be followed up with appropriately. So how do we get there? Within the US, a lot of health systems are forming partnerships, and OHSU is one of them. This is an overview of the area that we serve. We are the only academic medical center within this region. So we have a lot of patients that we serve and we have to think about. So OHSU formed partnerships in 2016 with Hillsborough Medical Center and Adventist, with the goal of transforming our members into a value-based care organization through partnership and innovation. When we formed our partnerships, we also formed the Office of Clinical Integration and Evidence-Based Practice, which is where we sit. And that was with the goal of integrating best research evidence to clinical practice. And we do that mostly by the development and implementation of evidence-based practices, with the goal of having one standard of care across OHSU Health. So our patients can receive the same standard no matter where they are entering the system. We have 3 deliverables. We do focus a lot of our efforts on guidelines, but we also do evidence briefs, which are quick clinical questions that we can usually turn around to our clinicians within a few weeks. but it's also really important that we are changing the culture within our system. So we do also offer a course where we are training our clinicians to use EVP practices, the grade methodology, so that they can conduct their own reviews and develop their own guidelines within their own departments. So a quick overview of our guidelines. There are a number of guidelines that we could select. So what we do is we have a council that works across our health system, which includes the chief medical officers, the chief nursing officers, and physician leads from each site. And they help to prioritize what guidelines we will be working on. And also to remove barriers to implementation. As I'm sure many of you know, there are many barriers, and it does take a lot of time and effort in order to implement a lot of these practice changes. So when we're selecting guidelines, we're considering our payer request, our quality data, clinician experience is very important, local and national trends, and also cost of care. So that helps to identify topics, and then we rank them, and then we select, and that's how we select our guidelines. We also have a matrix so that when we are going through this process, we are ranking different criteria, and that is really with the lens of the quadruple aim. We really want to ensure that we are keeping that in mind through all of our processes, which is including improved patient outcomes and experience, considering cost, but also with the extra lens of considering clinician experience, because we know that clinician burnout is a real thing that is a concern. And this is just a ranking of our different guideline topics and where they fill in the different criteria. As you can see, sponsorship is so important. So our program works very closely with clinicians. Without the clinician leads, we really can't be successful. They are the ones who are going to go back to their departments, and they're going to be leading this work to ensure that it is implemented and that change is actually happening. And this is our process. So once we identify a topic, we form interprofessional teams. We try to ensure that any specialty or any clinician that is going to be affected by the guidelines are at the table so that they can have a part in interpreting the evidence and also to be developing the recommendations. Our team is the one that goes back after we have scoped the guideline. We go through the existing guidelines and literature. We appraise using the grade methodology. We draft the guidelines and the recommendations with the input from the team, and then we develop the guideline and establish outcome measures to track over time. Implementation is extremely important and takes a very large team and able to achieve this. This is just kind of a basic overview of what we do. We collect baseline data, we develop communication, educational materials for our providers and our patients. We develop the decision support tools within our EHR to help with the practice changes. We develop the process metrics that we can track over time. And we also identify programmatic recommendations and needs, which sometimes leads to us developing business cases. And we also do an evaluation on our projects on the return on investment. So our program is fairly new. We started in 2016, and this does take a number of years sometimes to do the work. So this is what we have so far for the post-implementation data. One of our first guidelines was related to CF and pain and anxiety management. From the post-implementation data, opioid using encounters during hospitalization decreased by 9%. Opioid prescribing guideline, which is one we've been working on for years and are still working on, but our data has already shown that we've reduced over 4,660 opioid prescriptions during the 17 months of follow-up. And also we reduced average MUDD per prescription. Supplemental feeding, we didn't have any documentation within our system. So now that we have developed that, documentation has increased for providers. In heart failure, we've been able to show reductions of readmissions from 17.5 to 11%, and related readmissions decreased from 12 to 7%. We have a lot of lessons learned. This program cannot be successful without executive sponsorship and support. It takes a large team, but if we don't have support at the highest level, then our work won't be seen as important to clinicians and something for them to invest their time into. Also, it's really important that we include patients in the process. This is a part of the guideline development process that we are constantly working on because we want our patients' values and preferences to be included into not only the guideline, but most importantly into the implementation. We want to know their thoughts and feedback on how this will affect them in their care. It's really important to engage EHR teams as early as possible because we are making a lot of changes, developing order sets, changing workflow. So we need them at the table very early so that we can be making recommendations that are realistic. And the next one is ensuring appropriate stakeholder at the table. We try our best and we do invite a number of people to be part of the development process, but occasionally we do come across times when we've forgotten somebody, so we kind of have to pause and go back to ensure that we can go back and review the literature with them, the evidence tables, and ensure that they agree with the recommendations that we've made. We have to really focus our implementation efforts. This can be hard when there's a lot of ideas floating around, but we need to make strategies and tactics that are achievable. So that's really important for us to be doing throughout the process. And this is very time-consuming work, and there's a lot of competing demands. But this is also more than just changing tools, it's behavior change. So it takes a number of people and time to really go through and make effective behavior change. And also we wouldn't be successful if we didn't have partnerships. We have a medical librarian who's amazing, who works with us, and we really couldn't do it without them. And we're very lucky here to also have the Pacific Northwest Evidence-Based Practice Center. They are constantly mentoring us and giving us feedback because they are the experts in methodology, and we really rely on them. We have a data analysis team who is helping to develop the dashboards in the registry so that we can track our work. That's how we ensure implementation is successful, and we are using that data to inform the work that we're doing and moving forward what we should focus on. And we are very lucky also to have a health system effectiveness team here that helps us evaluate the return on investment, not only the economic part, but the patient outcomes as well. We have a great quality team here as well that helps us with implementation and the behavior change. And really, the way that we are successful within OHSU Health is that we align with other initiatives across the hospital, the integrated delivery system, population health, and value-based care. I'm not very sure how much time I have left. I can't see my clock.
Yeah, Mercy, it's Adrian. And in fact, if you could take the next maybe 30 seconds just to wrap up, and there have already been questions come through in the chat room, so folks are engaging. So looking forward to sharing those questions with you.
All right, I won't go over the other two components of our work, but I'll go ahead and take some questions. But I also wanted to put up here my email address, because if you wanted to contact me and have further information, this was a quick presentation. I would love to talk to you all further.
That's great, Mercy. Thanks so much, and a very informative presentation for you to talk about the process that you folks go through and all that's involved. In fact, I have questions, but I'm actually going to start with the chat room. So the first question is from Helen Wu, and she's asking, how do you prioritize which topics are the most important for you to work on, given the guideline content that's already available from other sources?
So we do that by looking across our health system and what our strategic initiatives are and where we can align in that case. So we have a number of initiatives at OHSU that are aligned with our integrated delivery system, and they have their own metrics. So we consider guidelines based on that, and also with our population health colleagues. So it's really alignment with other groups to have an idea. They have data about our overall patient population and know what our priorities should be.
Okay, that's
all right,
great.
well,
And
thank you so much. I was just going to say, I think we might want to move on to keep to time, but I'm sorry, go ahead, Adrian, I didn't mean to cut you off.
That's no problem. Just to say, Marcy, there are other questions in the chat room, so feel free to engage with folks, but you've also provided your email address to them, and they can also reach out. So thanks very much.
Thank you.
All right. And up next, we are going to be hearing from Candace Hamill. Candace, feel free to start sharing your screen as soon as you're ready. Okay, great. We can see your screen, but I'm not sure, you may have muted yourself.
Okay. I think I'm on now. Can you hear me?
Yes, we can hear you loud and clear.
Yeah. Okay. Good afternoon, everybody. We'll just. Okay. Okay. Hopefully you can see a full screen of my presentation because I'm seeing something different. But anyways. I'm here to present a project, a scoping review project that we did looking at methods papers that formally evaluated different ways of doing things to conduct rapid reviews. And just to say, I don't have any declarations of interest to declare. And the paper that with the results of this project was published in June in the Journal of Clinical Epidemiology. Unfortunately, it is not open access. So if you have a subscription or a license to the journal, you can get access to it. And thanks to my co-authors on this project. It was a lot of work, so they were very much involved. The main objective of this of the scoping review was to identify literature assessing one or more methods applicable for undertaking rapid reviews. So for example, comparing single reviewer screening versus double reviewer screening, or to find the literature comparing results of rapid reviews to those of systematic reviews. So comparing the same review, if you did it with using a rapid method, did it change the conclusions, for example? And we looked at this across all stages of review conduct. Just to note that we did publish our protocol before we started the work on Open Science Framework, and the link is provided there. And also just to note that this was one of the abstracts that has been published in the special supplement of the Cochrane database of systematic reviews. Just quickly, our methods. We looked at only English published studies for feasibility, and we went back to 1997 as that was primarily when rapid reviews first started getting mentioned in the literature. We searched several databases, all those listed there, including Epistemonikos. We also did some gray literature searching, looking at organizations that produce rapid reviews. We looked at the bibliographies of our included studies. We contacted experts in the field of rapid reviews, and we also looked at the time a recently published study that did the same type of work but around systematic reviews, and it's the Robson 2018 study. So we also looked at the bibliography of that publication. We started our title and abstract and full text screening using a set of pilot studies to make sure that we were screening the same way between reviewers. For title and abstract, we used a liberal accelerated technique in which we needed one reviewer to include a record. However, we needed two to exclude a record. And then at full text, we used the typical dual independent screening and resolved conflicts at this stage. For our data charting, we piloted it on 5 records. We had one reviewer extract all of the data, and we had a second reviewer verify everything that was extracted. And again, any disagreements were discussed and resolved. We, for data synthesis, myself and one of the co-authors, using some guidance from an existing publication by Andrea Trico and others, we mapped the studies into 4 main categories, and the focus of this particular scoping review, the results were on the formal evaluation studies. So we mapped these to the stages of conduct to identify any gaps in the research. We also evaluated the shortcuts against the Messier criteria, so the Cochrane methodological expectations of Cochrane intervention reviews, to see how closely or not these shortcuts met the Messier criteria. We also felt it was important, although we were looking for these formal evaluations, we felt it was important to create a repository of all of the available evidence that we could find. You know, different programs who published information around how they produce rapid reviews in their particular organization. So those types of studies fell under what we called development studies, and we had 4 subcategories within that. We also had a category around comparisons. So comparing the rapid reviews to the systematic reviews of the same topic, and not necessarily through formal evaluation, but just a generic comparison. And then last, we had a couple studies looking at evaluating the rapid reviews against Prisma and AMSTAR to see how closely they met the reporting criteria and the quality of conduct criteria. Then all the studies were narratively described and presented in tables. So we identified 90 studies, and we have listed them here: 14 formal evaluation studies, 65 development studies, 2 comparison studies, and 3 studies applying tools against them. We also identified 6 studies which we considered systematic review surrogates. So they were relevant but conducted on systematic review. So they would have fit more within the Robson study, but we felt it was still important to identify these. Just to note that the majority of these studies have been published since 2014. And then among the 14 formal evaluation studies, we had 10 that evaluated single shortcuts. And we had 4 which we deemed them as evaluating composite shortcuts. So for example, they implemented various shortcuts. So we couldn't really tell which shortcut was actually the shortcut that contributed to any differences in results, if there were any. So our main focus was among the 10 single shortcut studies. And just to note that 11 of these studies were published since 2017. So this is a fairly new emergence of studies in this area. So these are our overall results, mapping them to these key dimensions of the review process, which is by no means fully comprehensive, but this was just our kind of preliminary list of stages. And so this was including all 14 studies. So the composite evaluations counted for multiple shortcuts that were evaluated. And just to note that even within the formal evaluation studies evaluating single evaluations, they could have evaluated more than one, but independent of the other. So that's why we have 33 total evaluations among those 14 studies. And then within the 10 single evaluations, there was 16 single evaluations within these dimensions of the review process. So I'll go through the main ones here. I think I will run out of time if I go through all of them. But the main ones that I thought were most interesting, oh my gosh, so there was 2 studies under the screening area, the Gartner 2020 and the FAM 2016. They both looked at single reviewer screening. This was really the only comparison that more than one study evaluated. And Gartner concluded that it wouldn't be feasible to use this method for systematic reviews, but potentially for rapid reviews. Whereas FAM said that this is not a good way to do screening. There was just too many studies missed. Another one was the Nussbaumer-Straight. She looked at, I think it was 840 different abbreviated searches, different combinations of which databases to search, including gray literature or not. And they evaluated several, I think it was 60 reviews of the results of this. So depending on why I have the check mark and the X there, depending on which databases were being searched, some were recommended to use in rapid reviews, where others just missed too many studies. Another one under data extraction is the Martin St. James paper. They looked at extracting data directly from existing systematic reviews, and they found that this was a very good method of saving some time, that the quality of the extraction from the original systematic review compared to going back to the primary study was very good and saved a lot of time. And then there's a couple in here that we wouldn't necessarily consider methods of rapid review. For example, the Moore study looked at including knowledge brokers into the review process, and the Spry study looked at the impact of peer reviewing the search strategies. So these technically would be extra steps that not everybody would do in a typical rapid review or even systematic review. However, by taking a bit of time up front and including these extra steps, it actually could save time down the line, because you could have better questions being asked by including knowledge brokers, or you could have a better search strategy to identify studies that are more relevant to the question that you're trying to answer. And last, I'll just mention another Nussbaumer-Straight study where they looked at limiting to English-only publications, and they looked at a series of systematic reviews and removed any non-English publications, and this performed very well. So they concluded that it would be a good method to use for rapid reviews. Sorry, Adrian?
Yeah, no, that's fine. You've got your discussion, so it sounds like you're close to wrapping up. Yeah, you're close to your time. Perfect.
So what we notice is there's little overlap in the evaluations and even comparisons within a particular review stage of conduct. They differed on what was being evaluated. So it was really, there's not a lot of evidence for any particular shortcut that was evaluated. Another thing, just to say that the evidence is largely based on case studies. So for example, the FAM study evaluated 4 different shortcuts, and it used 3 systematic reviews as their cases. And then the composite evaluations, I mean, we included them, but there wasn't really anything we could say about the shortcuts independent from the other, because they just weren't evaluated that way. So it is best practice and recommended that if authors want to evaluate these shortcuts, that they should evaluate them independent of each other. And last, just to say that although some of these recommendations, the authors have concluded that they're valid shortcuts to take, it really is dependent on the question and the topic that is being asked in the review. So for example, if a topic was on nursing, you know, if the best search strategy is Medline, Embase, and Gray literature searching, for example, well, if you're doing a topic on nursing, then we really should search CINAHL as well. So just to say that you need to consider the topic and the research question that's being asked and decide whether these shortcuts are valid for your topic in particular. And that is all questions.
That's great, Candace. Thanks so much. While we're waiting for questions to come through the chat room, maybe I can just share a couple of mine. So here we are, here's the state of science. And you know, there's some information out there, some evaluations that have been done, and you've already sort of shared what some of the limitations are. After having gone through this, you know, you also are involved with producing rapid reviews, you know, with your own institution. What do you think the next step should be in terms of focusing efforts to further this area?
Well, I mean, we ran the search originally in January of 2019, and since that time, there's been a lot of research actually, and I've done some as well, on using artificial intelligence for screening for study selection at title and abstract level. So I think that has a lot of promise to decrease the amount of time spent screening, which is a large portion of many reviews that are done. And it also offers, I think, once, you know, there's some guidelines that are made, you know, strategies on how best to use AI within that, and trying to keep it maybe standardized across reviews being done by different organizations.
Adrian, it looks like you are muted.
And sorry, Celia, are we okay for time, or did you want to move on?
We are at time. We are actually at time. So thank you so much, Candace. Up next, we are going to, last but not least, we are going to be hearing from Eitan Agai. Eitan, go ahead and share your screen whenever you're ready.
Thank you very much. And I have to say that Candace's presentation is a very nice introduction to what I'm about to talk about, which is the next generation of systematic literature review platform called PicoPortal. So PicoPortal is a new machine learning power tool to aid citation screening for evidence synthesis. So what I'm planning to cover in the next 10 minutes is to talk about how to build trust in machine learning. This is a fairly new area that it's being researched for quite some time, but not implemented very aggressively. And then we will look at where in the machine learning is applied in PicoPortal. So for example, include and exclude prediction, study type classification, deduplication, highlighting keywords, crowdsourcing, and then we will break into question and answers. So just as a, take a quick glance at PicoPortal to give everyone a little bit of a context of what the platform is. This is the screening view of a reviewer. So a reviewer can immediately see the title of the citation, as well as the author and the publication, and even the access to the full text review. Anything that is blue color is basically hyperlinked to the source document. They also can see the abstract with highlighted keywords based on PICO criteria. And they can also review here on the top right, what they can see is the tool to help them select whether something should be, a citation should be included or excluded based on PICO criteria or any other reasons that they have. And lastly, they have the ability to tag each article that it's being included and also add some notes. So that will help them when they are compiling the information. Also, PicoPortal support full text review. And I wanted to spend a minute talking about trust. So first of all, when I talk about machine learning, I'm talking about the ability of a system to classify, to predict. So it's classification, prediction, and clustering. And when we talk about trust, trust is built when the classification, prediction, and data clustering help you make good research decisions. Those are some of our guiding principles. So we believe, and I believe, that we earn users' trust during the project duration. So as the project goes by, the user can choose whether or not to trust what the system is telling them, right? And we also make sure that any technique that is being applied in PicoPortal is being benchmarked against published research. So prediction of study results in systematic review is a hard problem. And if in this particular picture, if let's assume that the Chihuahua is an include citation and a muffin is a exclude citation, then the question is, how do we teach a machine to solve that? Well, that's not so easy to solve. And if you add on top of that, that each review has its own inclusion and exclusion criteria. For example, if you take a different review study, then you understand that the complexity of getting accurate prediction is somewhat hard. So what do we do? What is the approach that we're taking? We move with caution. So if we will take a traditional screening, like in this case, this is an active project that we have that has about 10,896 citations that were uploaded, and after deduplication ended up with 7,200 95, what we see is that the citation are screened in random order. If the red represent exclude and the green represent includes, every so often you have an include and most of the articles are being excluded. It's done fairly randomly. Also, if you have a larger team, more than a few people, then you need to allocate the resources manually, which is not an easy task to do. In many cases, the process itself is sequential and takes longer, meaning that in a typical process, you do the abstract review first, and then you do the full text review. And although there are available open source and commercial tools, they primarily resemble some sort of a spreadsheet-like, and they're not, some of them are not so easy to use. So using machine learning prediction, what we felt that would be more productive is to sort the citation in such a way that the most likely include will be first. So as you can see here on a project timeline, you can see that the most likely includes are first. And as we move along, you will see more and more excludes. So why is it important? It's important because in a Pico portal, we allow you to screen at the same time both the abstract and the full text. And as an abstract is deemed to be included, it moves into the full text bucket. Now, if you will allocate some resources to review the full text, what you will be able to do is to refine the inclusion and the exclusion criteria and feed it back to the group that is doing the abstract review, so they will select more appropriate articles. Also, over time, the users can confirm that the model is working for the project. So at the beginning, they will see more includes than exclude, but toward the end, they will see that most of the article or all the articles that they are reviewing are being excluded. And somewhere around, there is a golden bar where the user can reduce the resources. So if you have a dual review, for example, you might want to drop a person and say that, say that one reviewer is sufficient and the second reviewer would be the machine, as Cadence described, for example. And then if there are any differences, then adjudicator can make a decision, the final decision. Other areas that machine learning are being used within Pico portal is to classify the study type. Now here we proceed with caution. So here is one study type, but let's say we have many of them. What you can see is that there is some sort of an orange bar which we describe what study it is. So if we will zoom a little bit in, we will see that when the system is sure, when the system is not sure that this is a meta-analysis, it will just point out to you that this is a possible meta-analysis. But when it's sure that it's a systematic review, it will drop the word possible. So it will tell you, I'm quite sure that this is systematic review based on the confidence level. Now, we don't make the decision for the user. The user is still free to make their own decision, but this is some sort of a cue, like CUE, that let the user know what to expect even before they start reading the abstract for this particular doc. Now, Pico portal also have a very sophisticated deduplication tool. Like in this particular case, this is the dashboard. When we see 11,661 articles, we can see that the system identified 3,683 duplicates automatically. Now, with one duplicate, the system was not quite sure. Why? Perhaps the year of the publication is not identical, the publication journal is not the same, so it let the user decide. When the user decide, when we show them side by side the two citations, the user make a choice. We don't throw out their choice. We feed it back to the machine learning to improve the deduplication algorithm. Another element is keyword highlighting. So you can see here in the abstract, and I pointed out before, that Pico portal highlights for you different type of keywords. Now, why is that? Because keywords are a condensed form of the citation, meaning you can look at the keywords and get a sense of what you're about to read, which speed up the process. How do we do that? PicoPortal has the ability to analyze, to basically to find the frequency of each relevant word, but also in the context of PICO, of population, intervention, and outcome in this case, and say that the word such as adolescence is a population and a word as hospitalization is an outcome. Now, even though this is somewhat useful, it will be more useful if we will feed this information into a clustering technology, and now we will find a pair of words like Down syndrome or cerebral palsy, right? So now you have a pair of words that can be highlighted, and it's a much more meaningful than just a single word, and that's something that it's being done behind the scene. And the last thing that I wanted to point out is crowdsourcing. So we have a very smart crowdsourcing engine. Again, this is an active project with that many participants, right? There's no human management over here. The system basically allocates the articles using specific algorithm to maximize the efficiency, the overall efficiency of the review itself. This is kind of end of my presentation. I'm open for question and answers. And this is my contact information, iaguy@picoportal.org. Thank you.
That's fantastic, Eitan. Thanks so much for your presentation. I was looking forward to seeing this one. As we wait for some questions to come through the chat room, I do have a couple for you. I'm just curious, you've built this, what kind of groups have you managed to be able to connect with? Folks, what's the engagement been so far with respect to your work?
Yeah, so this is a work of love, I have to say that. I mean, this is something that I was dreaming of doing, and I actually took my dream into action. And as I built it during the pandemic period and kind of like brought it into a point where you can see the results over here, several groups engaged me. Some are government organizations, some are universities. And one of them described to me and said, until now I was driving on a gravel road, and now I feel that I'm on a highway. I mean, the fact that the user interface is so slick, that there is so much automation behind it, that everything is so transparent, I think it's quite empowering the users. They feel more relaxed, that they see a user interface that it's easy to work with. I also review the review rate, like how many articles people are reviewing within an hour, which typically a very good reviewer is doing about 100 articles per hour. I've seen that rates went to 140 and 150 articles or citations per hour by some of the reviewers. So the response is phenomenal, and this is a great platform to share my work of love.
No, that's great. It's nice to see those things come to fruition, right? Those works of love.
Absolutely.
Related to one of your points, you mentioned about screening citations and articles, and one that was in the chat was asking very much about, will that PICO portal be available for use for full text screening in particular?
It is available. People are doing full text screening. And one nice thing about it is that we're not an opinionated system. I build it in such a way that I'm not dictating to the user how to screen their information. So giving that into account, the minute that a citation is being considered as include, it moved into the bucket of full text. The system automatically behind the scene scrape the entire web and find out if there is a PDF files or the full text that it's outside of the firewall, and it automatically will download it for you, so you don't have to do that, and you can start your full text review almost immediately. I've seen in some of the projects that groups are allocating few people to do the abstract review and 1 or 2 people to do the full text review while the abstract review is taking place, and then they're feeding back as I said, the inclusion-exclusion criteria back to the group that is doing the abstract review to minimize the amount of includes or to maximize it, depends on what they're looking for.
Oh, that's great. Eitan, thanks so much. There are other questions that are in the chat room. And I know there was a question about whether it's free. And I recall from your abstract that it is free for academic use.
Yes.
Great. And feel free to connect with folks. This was the last session. I'm going to hand it back over to Celia in just one moment. I just wanted to say for myself, on behalf of Cochrane Canada, Cochrane US Network, really appreciated today's session and speakers. It was just such a pleasure to be able to highlight that we were able to feature some early career investigators as part of this. And certainly as part of what our desire was with the session was to be able to promote and encourage some networking, relationship building, and perhaps future work out of this. So I and I'm sure others as well, encourage you to continue the conversation. Thanks again so much. Celia, back to you.
All right, well, thank you, Adrian. And I would like to send out a big thank you to all of our speakers. We really appreciate you all taking the time to speak to us today. I'd love to extend a big thank you to our planning committee for their vision and their input, and also to AHRQ for hosting the meeting. Just as a little reminder, we will be distributing, we've recorded the meeting and we are planning to distribute that and make it available for you all. And we will also be requesting permission from our speakers to distribute their slides. Once we have that, we will also be distributing their slides. I would like to send out a special thank you to Elizabeth Stoger from the SRC. She has been very helpful in making sure that this day went on without a hitch. And so I just want to extend a special thank you for her. Well, and that concludes our day. Thank you all so much for your attention and for your engagement. And we look forward to collaborating with you all more in the future. All right. Bye, everyone. Thank you.
Thank you very much.
Thank you.